Everyone. On behalf of my conference co-chairs, Drs. Tom Saba and Stephanie Ware, and the Heterotaxy Connection, I am really delighted to welcome you back to our virtual conference, Facing Heterotaxy Together. Yesterday, we had a terrific array of talks covering definitions of heterotaxy and isomerism, and cardiac, gastrointestinal, respiratory and immunologic manifestations of heterotaxy. The day wrapped up with a really inspiring keynote address by Dr. Jerry Marks and heartfelt perspectives from parents and a very engaging Q&A session. I hope that, like me, you were inspired by this multidisciplinary conference, which really is one of its kind in our heterotaxy community, and by the collaboration between families and providers. Just a quick note to look for follow-up communication from both the HRC3, that's the Heterotaxy Research and Clinical Care Collaborative, and the Heterotaxy Connection about different ways that you can become involved, and we very much welcome that. So we have an equally great second half of the conference, and this is going to begin with a series of 5 talks. And after a brief break, we'll have 3 really fascinating cases that highlight the multidisciplinary challenges, questions, and even opportunities for research within heterotaxy. And we'll have a brief Q&A after each case, and then we'll conclude with a bit of a lengthier Q&A session. And just a reminder to please keep your microphones and videos muted unless you're directly participating in the conference. That's it for our introduction. And for our first presentation today, we have Dr. Emily Buchholz, whom I had the pleasure of working with at Boston Children's Hospital, but she is now a pediatric and fetal cardiologist at Colorado Children's Hospital, and she is assistant professor of pediatrics at the University of Colorado. And she is going to be speaking to us on current and future research in heterotaxy. Dr. Buchholz.
Good morning. I'm going to be talking to you about navigating heterotaxy, advances, challenges, and future horizons in research. I hope over the next 20 minutes, we will review current heterotaxy-related research and future directions. We'll discuss challenges of conducting heterotaxy research, review existing registry opportunities, and talk a little bit about the development of local heterotaxy registries. So as I was developing this presentation, I did a literature search to try and understand the current state of heterotaxy-related research. I started with a PubMed search that included terms of heterotaxy, atrial isomerism, polysplenia, and asplenia in the title or abstract, and then I parsed down the results to just scientific manuscripts, excluding case reports, commentaries, and reviews. I also excluded any articles where the primary focus was on complex congenital heart disease, or PCD, and in which heterotaxy was just a subgroup analysis. I wanted articles that were purely focused on patients with heterotaxy. This graph shows the absolute number of scientific manuscripts that were heterotaxy focused over the last 2 decades. You'll see that there was an increase in the number of manuscripts in the early 2000s, but over the last 10 years, the amount of scientific literature generated has been relatively stagnant. But what struck me most is that in a given year, there are only about 15 to 30 scientific manuscripts devoted to this population. And while heterotaxy may be rare, the complexity and severity of this diagnosis should open up multiple avenues of investigation. So what kind of content are we generating as a community? There have been several manuscripts devoted to the genetic origins of heterotaxy, definitions and diagnosis, clinical and surgical management, and outcomes. The focus in the vast majority of these manuscripts has been on congenital heart disease and primary ciliary dyskinesia, and this should come as no surprise to any of us since these are the most prevalent diagnoses, but also carry the greatest morbidity and mortality. On the genetic side, we've learned much about the genetic underpinnings of heterotaxy and some of the embryologic pathways that are involved. We've learned more about the constellation of comorbidities that segregate into different types of heterotaxy. And with that, we've also learned that our classification systems for heterotaxy are incomplete and do only a marginal job of predicting how these features cluster. We talked a little bit about this yesterday during the cardiac features of heterotaxy talk. This was a review from sick kids and 114 patients with heterotaxy who underwent cross-sectional imaging to evaluate atrial appendage morphology, bronchopulmonary, and visceral organ arrangements. Among those with definable morphology, approximately 40% had classic right atrial isomerism, meaning bilateral right atrial appendages, right bronchopulmonary patterns, and asplenia. And 40% had classic left isomerism, meaning bilateral left atrial appendages, left bronchopulmonary pattern, and polysplenia. However, classic patterns of isomerism were reached in roughly 20% of patients. The flowchart here shows the percentage of time that bronchopulmonary patterns and atrial appendage morphology differed by spleen status. And so you can see that among those with asplenia, the vast majority had classic patterns for a right isomerism at both the bronchopulmonary and appendage levels. However, among patients with polysplenia, only about 75 to 80% of patients had typical bronchopulmonary and appendage patterns for left isomerism. And then remarkably, there were 4 patients who had completely normal spleens, but abnormalities in bronchial and appendage morphology. This was the editorial that accompanied the analysis and highlighted the need for a new approach to classify heterotaxy. They make the point that although there are statistical associations among various cardiac and extracardiac anomalies, these are merely associations and not rules. And later in the article, they also state that the currently used classification systems do not work, but also emphasize the importance of individualized approaches to diagnosis based on a systematic segment-by-segment analysis of each part of the cardiovascular system. This is another example of how the patterns of left and right atrial isomerism break down in heterotaxy. This table comes from the ECHO textbook and was shown yesterday that most pediatric cardiology fellows use. It summarizes the various case series of heterotaxy patients that have been published in order to compare the incidence of cardiac anomalies seen in right and left atrial isomerism. You can see that certain anomalies appear to segregate well, like interrupted IVC and polysplenia, or complete atrioventricular canals and pulmonary stenosis or atresia in right atrial isomerism. But most are highly variable, and some could argue that there really isn't a consistent pattern when you look at it this way. There's also been a fair amount published on cardiac outcomes in heterotaxy. We presented many of these studies yesterday and discussed which patients are at particularly high risk of poor outcomes due to not only cardiac, but also extracardiac causes. This is a very simplified and, I admit, highly incomplete way of looking at cardiac outcomes in heterotaxy, but I do think it drives home the severity of the diagnosis and the urgency in finding novel solutions for these patients. So between 80 to 85% of patients with heterotaxy have congenital heart disease, which can come in all forms, but is usually complex and severe. Between 49 to 75% of those with heterotaxy associated congenital heart disease will ultimately be palliated towards a single ventricle pathway. And while single ventricle heart disease is more common in right atrial isomerism, it can also be seen in left isomerism and often co-occurs with other complex features like pulmonary or systemic venous abnormalities. As a result, these patients have very high postoperative and long-term mortality. So depending on the severity of the heart disease, mortality can range from 4 to 23% in the immediate postoperative period and can be as high as 20 to 40% in the first 10 years of life. The causes of death tend to be multifactorial, but are most commonly due to the cardiac or pulmonary disease. What is particularly alarming, though, is that there has been minimal improvement in the long-term prognosis of heterotaxy over time. So these data come from Boston Children's, a cohort from 1985 to 2014. The 10-year mortality rate in this study was 40%. And while there's been some improvement from the earliest era shown in red to the latter era shown in blue, black, and green, long-term survival did not significantly improve from the 1992 cohort to the most recent 2008 cohort. These data are a bit outdated since the last birth era ended in 2014, but at least anecdotally, I think that many of us who care for patients with heterotaxy know that this group remains at very high risk of both early and long-term mortality. So where are the opportunities for heterotaxy research and how do we start to improve outcomes for our patients? First, there is ample opportunity to improve our classification systems of clinical phenotypes. As we just saw, our current classification systems are incomplete and provide really limited information on prognosis. So novel ways of classifying these patients could help with risk stratification, screening, or even clinical and surgical management. Second, it's important to understand the relationship between these clinical phenotypes, genetics, and ultimately outcomes. This interplay between genotype and phenotype likely has significant bearing on clinical outcomes and again may help with screening and management. Third, we need better risk algorithms to do a better job of tailoring management strategies. We reviewed a few of the published risk models yesterday, but all were focused on cardiac anatomy, contained very little extra cardiac data, and were built using traditional risk modeling strategies. We can do better. Finally, we need to understand how multidisciplinary care can improve outcomes. And so this comes in the form of teams of physicians who are devoted to integrated heterotaxy care. But there are multiple challenges with studying heterotaxy. First, it is a rare disease. With a quoted incidence of 1 in 10,000 births, most institutions in the US will see between 10 to 25 babies with heterotaxy each year, which limits the interpretability of single-center studies. Second, there is considerable heterogeneity in phenotypes and management strategies. So the complex anatomy and physiology of heterotaxy, coupled with small numbers, limits our ability to pick up on differences in outcomes across clinical traits. And then finally, there is considerable institutional variation in both surgical and clinical management, such that the findings at one center may not be generalizable to others. And these challenges all point to the limited utility of single center studies and really understanding both the presentation and the outcomes of this patient population. So what about multi-center registries? In the field of pediatric cardiology, there are several registries that contain data on patients with heterotaxy. I've listed some of them here. Each focuses on a different type of heart disease, management strategy, or type of hospital encounter, but could ultimately offer some useful information on a select group of heterotaxy patients. I'm told that there are also a few pulmonary registries, such as the one run by the PCD Foundation. But one of the goals of the HRC3 collaboration is to leverage existing registries for research. And so this group has started to work on a few of these registries to advance them. But these registries also have their limitations. First, they are usually focused on single organ systems. So the cardiology-focused registries were designed to study common cardiac surgeries or complications and contain relatively little data on extracardiac disease. Second, these registries usually do not collect detailed anatomic data, either cardiac or extracardiac. They tend to use classic groupings or cardiac diagnoses rather than systematically entering data on segmental anatomy. Third, diagnostic and management strategies are incompletely captured. So it's not always obvious which diagnoses a patient was screened for, and many of the procedural and extracardiac diagnoses come from ICD codes. Fourth, aside from the Pediatric Cardiac Genetics Consortium, few contain rich genetic data. And then finally, these registries usually follow patients for a finite amount of time, such as through hospital discharge or occasionally out to a year or two. But long-term follow-up is virtually unheard of. And so there's a clear need to improve the multi-center data that's collected on patients with heterotaxy. Ideally, these data should contain rich information on cardiac and extracardiac anatomy, genetics, screening and management, and then outcomes across multiple organ systems. There are beginning efforts underway through the HRC3 in the form of toolkits to help sites create local registries that might be ultimately merged across institutions with common data elements. I'm going to give you an example of how the Boston Children's Heterotaxy Registry was launched and review some of the lessons that we've learned in the process of getting it off the ground. When we started the registry back in 2020, we started with the vision of creating a registry from which we can learn about diagnostic and management strategies for patients with heterotaxy. We wanted this registry to be inclusive of all heterotaxy-related diagnoses, so we involved representatives from all major subspecialties that care for patients with heterotaxy. We co-developed the registry with these representatives, asking specialists to come up with questions and data elements that they wanted to see collected. And then we implemented standardized data collection methods and reviews to validate the data that was collected in order to ensure consistency and maintain quality. Finally, we used standard data elements so that we knew where and how to abstract data easily. And this helped streamline flow and improve functionality of the registry, even when we had more than one research assistant working on the registry at a time. This process did not come without multiple rounds of iteration that include feedback from stakeholders, edits to data forms and the manual of operations, and onboarding of new research assistants. But the goal was ultimately long-term sustainability and ideally scalability across institutions, which requires funding, resources, and personnel. So for the Boston Children's Heterotaxy Registry, we included all children followed in Boston from 1890 to present with a diagnosis of heterotaxy who underwent some type of cardiac intervention. Patients were identified using filer codes, which is a diagnostic coding system used in Boston, and reviewed by the team for inclusion. And this registry included patients who were born locally as well as those referred by other institutions. After the initial intake, that initial intake, we collected information on cardiac, pulmonary, GI, and surgery, immunology, and genetic data. And we collected information on anatomy, history, screening, and diagnostic tests that were performed, and then ultimately the management at Boston Children's. After that initial intake, any subsequent imaging, diagnostic testing, and procedures were collected on follow-up forms. And then we collected information on several potential outcomes, including death, cardiac transplant, listing, and receipt, final cardiac circulation, growth and enteral access surgeries. For individual surgical interventions, we also collected details on duration of mechanical ventilation, length of ICU and hospital stays, ECMO, pacemaker placement, operative or cath-based cardiac interventions, and frequency. To date, we've compiled the registry from 1990 to 2014 and are working on updating the registry over the last 10 years. There are about 260 patients in the database for whom we have a minimum of 10 years of outcomes. We're just starting to explore potential research questions, but these will likely fall in the domains of quality improvement, descriptive studies, and risk prediction or stratification. So examples of questions that we might be able to ask could be what percentage of patients undergo routine screening for malrotation, receive referrals to immunology for splenic function assessments, or undergo preoperative screening for ciliary dyskinesia. What is the prevalence of extracardiac anomalies in heterotaxy? And what are the strongest cardiac and non-cardiac predictors of long-term survival in patients with heterotaxy? I thought I'd give an example of one project that's underway where we're trying to refine the classification systems for heterotaxy using data from this registry. So rather than using the typical definitions of right and left atrial isomerism, we wanted to see whether there might be other clinical phenotypes that offer prognostic utility. So we asked the question of whether we could use unstructured machine learning algorithms to segregate the data into anatomic phenotypes. To do this, we've applied principal component analysis and hierarchical clustering models to 47 cardiac anatomic variables. And with that, we were able to identify 5 clusters of cardiac phenotypes. So cluster 1 had a predominance of right dominant atrioventricular canal defects, double outlet right ventricle, and pulmonary stenosis or atresia with TA-PVC. Cluster 2 was similar to that of cluster 1, but with left dominant AV canal defects. And these 2 clusters are what most would think of as being their kind of more typical right atrial isomerism. The remaining 3 clusters consisted of those with left-sided obstructive lesions and interrupted IVCs for cluster 3, transposition of the great arteries with pulmonary stenosis or atresia for cluster 4, and then a mixed bag of lesions with an interrupted IVC for cluster 5. And using these clusters, we looked at how often patients in each cluster were classified as asplenia or polysplenia. Interestingly, cluster 1 and 2 were more often classified as asplenia, but there were still a fair number of patients who had been labeled as polysplenia. Clusters 3 through 5 were more commonly classified as polysplenia. We also looked at the frequency of the time that patients underwent single versus biventricular heart surgery. So clusters 1 and 2 were more likely to undergo single ventricle palliation, whereas those in clusters 3 through 5 were somewhat more divided. Cluster 5 almost very rarely underwent single ventricle palliation. When we looked at survival, patients in clusters 4 and 5, that's shown in brown and purple, universally did well. You'll recall that cluster 4 tended to have a high predominance of transposition of the great arteries and pulmonary stenosis or atresia. And cluster 5 was patients with interrupted IVC, but other miscellaneous features. The other 3 clusters had worse survival during the early childhood years. Interestingly, when we stratified the results by the type of surgical repair or palliation that was received, we saw marked differences. So cluster 4, shown in brown, again did universally well regardless of the type of surgery, whereas clusters 3, shown in green, and cluster 5, shown in purple, did much better with biventricular repair. Almost all patients in clusters 1 and 2, those are the unbalanced canals, underwent single ventricle palliation. There were a lot of nuances as to who undergoes biventricular repair versus single ventricle palliation, but I think that these data start to point towards phenotypes where there might be a preferred surgical strategy. So where do we go next? The HRC3 is working on developing guidance for institutions to develop local heterotaxy registries. And then we've discussed some possible linkages to some of the cardiac registries to obtain more genetic data or robust follow-up. So I think the future is bright for heterotaxy research. And we hope that there will be much enthusiasm for exploring these multi-institutional collaborations. Thank you.
Thank you so much. That was such an insightful and thorough talk, and really encapsulated well where the field has been from a research perspective, and some of the needs moving forward, and a lot of encouraging signs in terms of especially multi-center collaboration, and being a little bit more nuanced in how we think about children with heterotaxy. Thank you so much. So next, I'd like to introduce Dr. Gabrielle Geddes, the Medical Director of Cardiovascular Genetics at Riley Children's Hospital, and she is going to be speaking about practical considerations of genetic assessment for patients with heterotaxy.
Hi, I'm Elle Geddes. I'm a medical geneticist at Riley Hospital for Children, and I'm going to go over some of the practical considerations of genetic assessment for patients with heterotaxy. And so our topics for today that we're going to try to address is how to talk about genetics with families, at least one approach, the overview of some of the genetic etiologies of heterotaxy and how heterotaxy develops, when to order genetic testing and what test to order, and the role of a genetic counselor versus a medical geneticist. And when thinking about how to talk about genetics to families, I typically use analogy. And the analogy I use is a library analogy. So I say your genome's like a library. It has all the information that makes up everything that's you. It's organized into these sort of bookcases called chromosomes. You have 23 pairs of chromosomes. You know, one comes from mom, one comes from dad. And on the bookcases are all the books, are all the genes. And we have over 20,000 genes, but we've associated disease with maybe a third of them. So we really have a lot to learn about genetics. And in addition to not knowing what all the genes do in regards to disease, we also don't know what all the changes do. So we really frequently will find variants or typos in our genes and in our genetic material. And most of them are benign or not disease causing. And so the example I use is typically, if you've ever seen color spelled with a U, C-O-L-O-U-R, a spell check might mark that wrong, but your brain reads right through it, knows exactly what it means. But you can have disruptive changes that look really wrong, but get the message across, while more subtle changes might change the message. And whether or not that's a significant change to the message can sometimes be hard to figure out. And then you can have, again, major disruptions that get enough of the message across. And that exact same change in a different place can disrupt the message. And so I try to always set up families to expect variants. They're in variants of uncertain significance when they get genetic testing back. And some of that is to help make it easier when those results come back, and make it easier for families to understand. And part of that is because we have lots of different variant types, and it's sort of amazing to think about, but the American College of Medical Genetics and Genomics only published formal guidelines for how to classify coding variants in 2015, so less than 10 years ago. And those guidelines are still fairly subjective and are being tweaked. And so one thing you want to be very cautious of when talking to families is use of the word mutation. The reason being that mutation is sort of thought of as clear disease causing. And especially in heterotaxy, we get a lot of variants of uncertain significance back on panels. And so I think that it's really important to set them up to expect variants. And when talking about variants, to use kind of more neutral language to avoid confusion as much as possible. And we have these 5 classifications. Benign and likely benign variants aren't generally reported. Some variants of uncertain significance will ultimately be reclassified to that and show on a report. But then we have variants of uncertain significance. And if you look at this graphic over here, we have the probability of pathogenicity, and we have 0.05 to 0.949. So variants of uncertain significance and probability of pathogenicity, while all these sections are equal, it actually spans the majority of variants. And what we classify for possible probability of being disease causing. And then we have likely pathogenic variants and pathogenic variants, which are considered to be disease causing, but may not be consistent with a diagnosis, depending on if a disorder is associated with autosomal recessive disease and things like that. And so when we're explaining genetics, we often say, like, this gene causes this thing, and disruption of this gene causes this disease. But again, especially in heterotaxy and autosomal dominant forms of heterotaxy, there can be a lot of variable penetrance and expressivity. And those are the fancy words for saying, people have all different severities of laterality anomalies and may or may not have clear laterality anomalies. And this can occur in siblings, where having a mild sibling with a diagnosis might not inform the severity of the next sibling if they are also affected. And so, when we're talking about the variable penetrance and expressivity, I say, you can be genetically purple, but you may or may not look purple, and you can be all different shades of purple. And that brings us to some of the genetics of heterotaxy. I think the first thing to review is what tells us left versus right. And so early in development, we have 3 ways that we define sides of ourselves. The one is anterior posterior, so head to tail. Dorsal ventral is back to belly. And then we have the left-right axis, which is the one we focus on for heterotaxy. And so what really tells us left versus right? And so there is an organizational structure in early development that we call the node that's responsible for signaling left versus right to the different parts of the body, ultimate body, like the lateral plate mesoderm and organ primordia. And so, ultimately, we get those signals via a few ways, and they do rely heavily on ciliary function, both from a motor perspective, from actually sort of moving proteins and disrupting gradients and sort of signaling from that way, and a sensory standpoint of sensing those differences and then having responses based on what they're sensing in the environment. And the heart is the first organ that expresses laterality. So the heart is often disrupted in patients with heterotaxy. And that's one of the reasons why congenital heart disease and cardiac defects are heavily focused on in heterotaxy, even though not all patients with heterotaxy have cardiac anomalies. And then thinking about genetics of heterotaxy, there's also multiple ways to group the different causes. And one that I like to use is heterotaxy, to start, is heterotaxy the primary issue, or is it a symptom of something else? And then the other thing that can be important to think about, especially when thinking about testing, is what is the underlying type of genetic disruption? And so classifying heterotaxy, again, this figure sort of shows us, okay, first we want to determine, is this heterotaxy or these laterality anomalies a symptom of a different syndrome, or are they the primary issue? And so when we have them as a feature or symptom of another syndrome, those can be sort of broadly across different genetic types of anomalies. So we can have chromosomal anomalies like trisomy 13 can have laterality anomalies. We can have copy number variants like 22q deletion syndrome can be associated with laterality anomalies. We can have single gene disruptions like primary ciliary dyskinesia and Bardet-Biedl syndrome. And then we can have, well, it's not associated with a syndrome and seems to be the primary issue on itself, which often are single gene defects and or multifactorial. And so heterotaxy can come in chromosomal anomalies, copy number variants, single gene defects, and be in inheritance patterns of autosomal dominant, autosomal recessive, and X-linked, and really just span the entirety of genetics and inheritance modes and anomaly types. And so another way that I like to think of it, which is kind of simplistic, is grouping it into primary patterning anomalies and primary ciliary dysfunction. And so I think that it's nice to think of things this way, because when you're thinking about ciliopathies and ciliary dysfunction, you can see a lot of different clinical implications of those, where a lot of times I think of patterning anomalies as, well, once you're born, however you developed, that's how you developed, and how your health goes from then on is often largely based on sequela of the congenital anomalies you may or may not have. Whereas the ciliary dysfunction, that has different specific treatment guidelines, even in the syndromic forms like Bardet-Biedl. And so looking at when to order genetic testing and what to order, trying to sort of summarize the different types of genetic testing we have available is across the entire spectrum of what can cause heterotaxy is kind of overwhelming. And so we have our tried and true karyotype that only looks for large chromosomal anomalies and large structural anomalies. And those generally aren't helpful in patients with heterotaxy unless you have a really specific suspicion. Additionally, those can only be done in samples of actively dividing cells. So you can't do it with a cheek swab or anything like that that extracts DNA. We also have chromosomal microarrays that look for genome-wide copy numbers, but they can't detect single gene disruptions or sequence variants like those positive of primary ciliary dyskinesia, which is a major changer in care. And then we have heterotaxy panels, ciliopathy panels, congenital heart disease panels, lots of different panel types to choose from. And those will look for sequence variants and typically deletions or duplications of their specific gene list. And so the utility of the panel depends on what genes are on it. And so you can have 2 heterotaxy panels from 2 different companies lined up side by side that end up with very different coverage of different genes and different potential disorders. The other thing to keep in mind with panels is they ask, are there changes in these genes? And especially with a large number of recessive disorders, ciliopathy panels and heterotaxy panels often come back with variants of uncertain significance. So again, when you're doing those, you want to really set your family up to expect some variance, some quote abnormal result, but it doesn't mean that you found an answer or even that that change means anything. And then as we get more into availability of genomic testing, we have exome and genome testing. And so especially for genome testing, it can detect genome-wide copy number variants and sequence variants. And the difference in genomic testing is the question that it asks is, are there variants that explain what is going on with this patient? And so you have to make sure that you're providing the lab with a really good description of what's going on with the patient. And oddly enough, you often are less likely to get variants of uncertain significance, depending on the phenotype you provide and the lab you use, because if they find a single variant of uncertain significance in a recessive disorder, that's unlikely to be related to the patient, what's going on with the patient. So they often don't report that. Whereas a gene panel, where you're focusing on what variants are in this list of genes, is more likely to, well, has to report those for the most part. And so you can also sometimes help manage the confusion related to variants of uncertain significance based on the testing you choose. And sometimes the broader test reduces confusion, though it's more complex and you have to sort of be familiar with it and understand how it works and what lab you're using to really navigate those things. And so as an ideal, I think that patients with heterotaxy, that seems to be the primary problem, would undergo genome sequencing for copy number variants and sequence variants, but we don't live in an ideal world. So what do you order? And so again, ideally, all patients with heterotaxy should be evaluated by a medical geneticist to phenotype and choose testing, because we often know those nuances. But we also know that geneticists are few and far between, unfortunately, and often there can be long wait lists that make the practicality of this difficult. But all patients with heterotaxy should have clinical genetic testing that should at least include copy number variant and sequencing of genes that at least cover primary ciliary dyskinesia genes due to the care implications. The other thing that's sort of odd to think about is genetic testing isn't really a one and done thing for the most part for the tests we're thinking about for heterotaxy patients. So a microarray, for the most part, you're probably, at least newer arrays, you're probably going to be able to say yes or no. Are there significant copy number variants within the resolution reported by this lab? So you don't necessarily need to repeat tests like that. However, with sequencing, especially as we get newer technology and new knowledge, you can increase the potential for diagnosis over time, as well as increase the potential for accurate variant classification. And so that brings us to, what is the role of a medical geneticist and a genetic counselor? And most people don't know the difference between these. And so a genetic counselor is the hero of medical geneticists, and typically someone we partner with closely, but can be independent depending on resources. And so they are a clinician who's completed a master's degree in genetic counseling, and they can meet with patients and families and analyze family history patterns, review genetic testing options, and review results. And they can help navigate the practical aspects of genetic testing regarding insurance companies and cost and those sorts of things, as well as the nuances of testing that we've sort of referenced. And then a medical geneticist is a physician who's completed a residency in clinical genetics and genomics. And so while genetic counselors have clinical training, they don't have medical training. And by that, I mean, they can't perform examinations or do medical management or those sorts of things. So they have to partner with a physician to help assist in those things. And they are great team members and sometimes the only genetic resource that you might have. So partnering with them and being able to communicate openly with them, especially if you don't necessarily have access to a medical geneticist, can really help. Again, especially with heterotaxy, since we do get, if you're using panels, we do get lots of variants of uncertain significance very commonly. And you want to make sure that you're reducing confusion and reducing anxiety as much as possible for the family about those things. And so the take-home messages are: genetics is complex and constantly changing. Even though your DNA doesn't really change, our ability to analyze it does. Genetic testing is all about the details. Abnormal testing doesn't mean there's an answer. Normal testing doesn't mean there isn't an answer. And then all patients with heterotaxy should have testing for copy number variants and testing that covers sequencing and deletion duplication of at least primary ciliary dyskinesia genes, but ideally more broad. Okay.
Thank you so much, Dr. Geddes. That was such a clear presentation of a complex and nuanced topic. I certainly struggle myself to understand it, but that was certainly very helpful, and I hope information that we can all take back to our own centers and put to use. I'm very excited to introduce our next speaker, Dr. Cecilia Lowe. She will be speaking to us about cilia and respiratory dysfunction in congenital heart disease and heterotaxy. She is the professor and chair of developmental biology at the University of Pittsburgh and is very experienced in the overlap of cilia function and congenital heart disease. We're very fortunate to have her speaking with us today. Dr. Lowe.
Today, I'd like to share with you some work we've done in the past looking at ciliary respiratory dysfunction in congenital disease patients with heterotaxy, specifically addressing whether they may have undiagnosed PCD. Congenital disease patients with heterotaxy are well known to suffer higher morbidity and mortality that is associated with post-surgical respiratory complications. And so relevant to this is, in fact, the knowledge that airway clearance and left-right patterning both require multiciliary function, as shown here. Respiratory epithelia from the nasal epithelia of a human subject, you can see normal coordinated beat motion that is responsible for mucociliary clearance. And then on the right, you can see a mouse embryonic node with monociliated cells that show this rotary motion across the surface of the node in the early embryo that establishes a gradient from right to left that is involved in setting up the left-right body axis. So multiciliary function in both of these contexts play an important role. In the left for mucociliary clearance, and the right for setting up the left-right body axis. So this suggests that, in fact, heterotaxy patients could in fact have respiratory dysfunction from multiciliary defects, and that same multiciliary defects may explain the heterotaxy those patients exhibit. So this then leads us to the question whether in fact these heterotaxy patients might actually have undiagnosed PCD, primary ciliary dyskinesia, which is a disease associated with multiciliary defects. So PCD, as you know, is due to mucociliary clearance defect due to respiratory multiciliary defects, and they can have cartilaginous syndrome, ascites versus totalis, or heterotaxy of rhabdomyocytis. And PCD is now known to be a monogenic recessive disorder with more than 40 PCD genes identified that's important for multicilia function. And so here are some examples of what PCD might look like. This is in a mouse model PCD. On the top is the tracheal airway epithelia of a wild-type mice. You can see normal cilia beating motion that's coordinated. On the bottom are the airway epithelia from a mouse with a DNH5 mutation. So this is a PCD model. You can see many in multicilia and some slow dyskinetic motion of some of the cilia. And this is from a top-down view where you can see the same, but in different perspective. And then on the right-hand side is, in fact, the same video that you saw earlier from a wild-type embryo showing multicilia in the embryonic node. On the bottom actually is a video also playing of the cilia from a DNH5 mutant mouse. And if you look carefully, you can see these toothpicks across the surface of the node. Those are cilia that are immotile in this DNH5 mutant. So this is multicilia defects both in the airway, the node, in the context of PCD. And here's just an example of a PCD patient with CTEC65 mutation, showing in this case stiff motion with incomplete stroke associated with the nasal epithelia cilia. This is a little unusual because most PCD patients show more immotile cilia and with only very poor movement of some cilia. So this is more a motion that we normally see. So to address the question whether in fact heterotaxy patients have undiagnosed PCD, we recruited patients with congenital disease with heterotaxy from Children's National Medical Center in collaboration with Dr. Linda Leatherberry, recruited 45 subjects and conducted 2 tests to determine whether they have PCD. This includes conducting a nasal scrape to obtain nasal epithelial tissue to do video microscopy to look at ciliary motility. And we also measure nasal nitric oxide levels from the nasal sinuses, which is typically very low in PCD patients. And so here are the video microscopy obtained from the nasal epithelial tissue of 3 heterotaxy patients on the bottom. This is that same video we saw of a normal subject. You can see there's asynchronous motion, stiff incomplete stroke. This is actually somewhat reminiscent of that CCDC65 subject. And here is a patient that shows abnormal ciliary motion that we would describe as wavy. So out of the 45 subjects, 18 of them actually show ciliary dysfunction. So 41% showing this very high prevalence of ciliary dysfunction amongst the congenital disease heterotaxy patients. What we noted is that most of the heterotaxy patients actually retain very significant amount of ciliary motility, but the motion is very abnormal. And as I said, this contrasts with more immotile dyskinetic cilia with limited range of motion in PCD patients. So we also measure nasal nitric oxide, as I mentioned. And what we found is that in patients with ciliary dysfunction, they exhibit very low nasal NO. So this is measuring nasal NO in nanoliters per minute. So we just look at the bottom right, look at subjects that are greater than 6 years of age. And these are patients with ciliary dysfunction, BCD, A, B. And then here are the controls, and here are the congenital disease heterotaxy patients with normal ciliary motion, and here are the PCD subjects. And you can see the PCD subject had very, very low nasal NO. And we can see that those with normal ciliary motion look very much like control, which is much higher than the PCD subjects. But in the ones with ciliary dysfunction, we can see that they have much lower NO. And in fact, this category of patients show NO levels that are near the PCD levels, although mostly they're still higher than that of the PCD subjects. So what we find is that the patients with ciliary dysfunction do have reduced NO levels, but they are mostly all above the PCR cutoff value, which is 77 nanometers per minute in subjects 5 years and older. So to further explore whether they may have any evidence for having PCD, we did whole exome sequencing analysis of 25 of the heterotaxy CHD subjects and looked for mutations or variants in known PCD genes. And in fact, we found no compound heterozygous or homozygous mutations or variants in known PCD genes. 2 of the 13 heterotaxy CHD patients with ciliary dysfunction actually did harbor variants in known PCD genes. One patient actually had a heterozygous mutation in a known DNA I1 founder, actually has a heterozygous known DNA I1 founder mutation. Because it's heterozygous, of course, it cannot cause PCD. We also had another patient that had 2 heterozygous rare variants, one in DNH5 and one in DNH11, both PCD genes. But again, because they are heterozygous, they do not fit the classic model of a monogenic recessive disorder for PCD. So presumably by themselves, they cannot cause PCD. We also sequenced additional heterotaxy CHD patients that were recruited from Children's Hospital Pittsburgh. This is after I moved to Pittsburgh, and found that in fact, these additional heterotaxy CHD patients, none of them actually have compound heterozygous or homozygous mutation known PCD genes. So really show that in fact, the classic genetic model for PCD does not fit what we observe in heterotaxy CHD patients. And in fact, it would suggest that there's probably more complex genetic model disease underlying the ciliary dysfunction in PCD in the heterotaxy CHD patients, and that it may involve oncogenetic interactions, perhaps including between PCD and non-PCD cilia-related genes. So overall, then these findings suggest that the heterotaxy CHD patients' ciliary dysfunction actually have phenotypes that don't conform to classic PCD, and they're not likely to have undiagnosed PCD. And so this, in fact, is supported by the findings from the Mucociliary Clearance Consortium, where they conducted a large retrospective study and then also a prospective study that showed the incidence of heterotaxy and heterotaxy congenital disease among PCD patients is very low. So for heterotaxy, it's 6.3% in the retrospective study, 12.1% prospective study. And for heterotaxy with congenital heart disease, it's very low, even lower, 2.3% in the retrospective and 2.6% in the prospective study. So this is consistent with why when we looked at heterotaxy CHD patients, we really found no examples of PCD, that in fact, PCD patients with heterotaxy congenital heart disease is very low. And so this finding is kind of surprising because we have looked at several dozen mouse models of PCD in my lab over the years, and we show that they all have a high incidence of heterotaxy. So in a DNH5 mutant model, data shown here, we can see 40% have heterotaxy, 25% situs soletis, 35% situs inversus. So generally, we see nearly half of all the mutants in any PCD line will have heterotaxy. And then we see that in fact, congenital disease is typically only seen in the mutants with heterotaxy. And in fact, almost all the mutants with heterotaxy will typically have complex congenital heart disease. So this finding is quite different with what's seen in the PCD patients in the study that I just showed you earlier. And so for the observations from the PCD patients together with the mouse data, we would suggest that there's a depletion of heterotaxy and heterotaxy with complex CHD in the PCD patient population as compared to what we know is observed in the PCD mouse models. So this would suggest that human fetuses with heterotaxy CHD harboring PCD mutations may be dying in utero and are not represented in the clinical population. And I should mention that in our analysis for heterotaxy in our PCD mouse models, we typically are harvesting the fetuses before birth. And that is to make sure that in fact we don't lose any of the animals that are born, because if they're born dead, oftentimes the mother will eat up the pups, and so we really won't know what the distribution of phenotype is. So in fact, it is important to note that our analysis is also done with fetuses harvested in utero. So, so consistent with this notion that fetuses, human fetuses with heterotaxy CHD may in fact be lost or dying in utero, is in fact that it's been reported that there's very high intrauterine death of around 30 to 60% in human fetuses with heterotaxy and complex congenital heart disease. So these are really depleted and underrepresented in the PCD patient population. So then we believe that based on these and other findings, that heterotaxy CHD patients probably don't have classic PCD, but we propose that they may have a variant type of ciliary dyskinesia, or maybe we might refer to them as having VCD, and that this ciliary dyskinesia, a different type, may actually cause milder respiratory symptoms and disease. And I say milder because we typically don't see neonatal respiratory distress in newborn congenital disease patients with heterotaxy, even though they may have ciliary dysfunction. And so we think that maybe respiratory symptoms of disease could be exacerbated by the surgical procedure for palliation of the congenital heart disease, and that this is what underlies the increase in post-surgical respiratory complications. And so to see if in fact this ciliary dyskinesia is indeed associated with increased respiratory complications, the subjects that we looked at previously in Children's National Medical Center, we followed up to look at post-surgical outcomes. And you can see that those with ciliary dysfunction show more in the way of respiratory complications compared to those without ciliary dysfunction, p-value 0.006. They also show increased total tracheostomy, as well as increased use of inhaled beta agonists, which indicates that in fact they do indeed have respiratory problems, and that the use of a bronchodilator is needed. And so indeed, ciliary dyskinesia in heterotaxy CHD patients are associated with increase in adverse post-surgical respiratory outcome. So of course, one thing that we don't know is whether this increase in adverse respiratory outcome is really related to the role of cilia in mediating mucociliary clearance. And in order to address that question, we really have to measure mucociliary clearance in these patients. And so in collaboration with Tim Tokaran, a biomedical engineer in the Department of Medicine, and Philip Adams, a critical care anesthesiologist, we developed the ability to measure mucociliary clearance in infants in the CICU. So Tim developed the use of a nasal cannula to deliver technetium sulfur colloid into infants that undergo congenital cardiac surgery. And then this deposits the radioactivity in the airway and the lung. And then a portable gamma camera is placed above the infant. And then over a 30-minute period, 1 minute scans are conducted to measure radioactivity in the lung and airway. And with this, then we can measure airway clearance. And this is at T0 and 30 minutes later. And you can see this radioactivity in this region of the lung is cleared over that time frame. And so if you look at preoperative scans, you can see there's a great deal of airway clearance. And that's shown here for a single subject over time. Over 30 minutes, you can see that radioactivity is decreasing because it's being cleared from the airway. However, postoperatively, if you do a similar scan, you can see there's little or no airway clearance. So essentially, what we found is that within 20 to 48 hours postoperatively, we cannot detect any airway clearance in these patients that have undergone congenital cardiac surgery. However, interestingly, after 48 hours, we begin to see divergence into airway clearance between different subjects. So in preliminary, or I should say in pilot study, we looked at pre-op mucociliary clearance and then look at how it relates to post-op respiratory support. And what we find interestingly is that the higher the pre-op mucociliary clearance, the lower the need for post-op respiratory support in the way of mechanical ventilation days, or in the need for non-invasive positive pressure ventilation days. And so this really supports the notion that pre-op mucociliary clearance function indeed plays an important role in predicting post-op respiratory outcome, and that in fact this pre-op mucociliary clearance indeed is related to the post-op respiratory outcome. So in conclusion then, patients with congenital disease associated with heterotaxy do indeed have a high incidence of ciliary dyskinesia, but we think this is largely distinct from PCD, and such ciliary dysfunction can increase the risk for post-surgical respiratory complications. We think that further studies are clearly needed to explore the role of ciliary dysfunction in post-op airway clearance function, and that indeed we would like to measure how airway clearance function may be related to ciliary motility. And then we also think that it might be worth pursuing looking at the potential benefit of perioperative pulmonary support and reducing post-op respiratory complications in heterotaxy congenital disease patients. With this, I'd like to thank you for your attention. There are many people that have contributed to the work. I'd like to especially acknowledge 4 very talented fellows that over the years have contributed to this work, including Nita Knocklick, Andrea Garrard, who I believe is participating in this symposium, and Eileen Stewart, Philip Adams, as well as help from Timothy Corcoran, the faculty in the Department of Medicine that developed the MCC scan, as well as pulmonologist Daniel Weiner, Jeff Curlin, the design of our experiments, and of course, Linda Leatherberry, and also the Mucociliary Clearance Consortium, Michael Knowles, McGee Lee, Adam Shapiro, Mamuna Zarawala, that played an important role in getting us really moving into this area of looking at mucociliary clearance in the airway of congenital disease patients with heterotaxy. With this, I'd like to thank you for your attention.
Thank you so much, Dr. Lowe. That was an absolutely fascinating talk. This concept of individuals with heterotaxy who don't necessarily conform to classic definitions of PCD, but nonetheless seem to have some sort of impaired clearance, and this variant of ciliary dyskinesia concept is something we very much feel at the bedside in the cardiac intensive care unit after surgery. And the idea of pre-op respiratory clearance is something very front and center for many of us. So thank you so much for that talk that underscored those concepts so beautifully. So we're going to shift gears for a moment and think about long-term outcomes in heterotaxy. And for that, we're fortunate to have Dr. Chris Broda, who is an adult congenital heart cardiologist and assistant professor of pediatrics at Texas Children's Hospital and the Baylor College of Medicine. Dr. Broda.
Hello, and thank you very much for the invitation to discuss caring for the adult with heterotaxy. My name is Christopher Broda. I'm an assistant professor at the Baylor College of Medicine, Texas Children's Hospital in Houston, Texas. And it truly is an honor and a privilege to be invited to the Heterotaxy Connection Conference and to discuss facing heterotaxy together. Thank you very much. To start with my disclosures, for the most important of which is that I'm an ACHD cardiologist, and focusing really mostly on the heart. I need to mention that I'm part of a large group focused on the care of adults with congenital heart disease. And within the group, I'm further focused on helping patients with heart failure, and I follow patients who are on LVAD devices and help them get to transplant if that's sort of what they need. Must start the talk by discussing the improved survival into adulthood for people who have congenital heart disease. So we really owe the pediatric cardiologists and the congenital heart surgeons our gratitude for all their dedicated work to improving survival for patients with congenital heart disease. And survival is most improved and striking for those with complex congenital heart disease. You know that patients with heterotaxy syndrome, also isomerisms, are often born with extremely complex congenital heart defects, some of which were nearly universally fatal in childhood, but now we have more patients living to adulthood. It's really important to, and this talk is not about transition, but I must mention transition because it's so important. Transition from being a child to an adult, or pediatric clinic to the adult clinic is an important time in people's lives because we're thinking about jobs and education, potentially family planning or pregnancy for women. And then also over time, patients will need to assume the care responsibility for their health care when before it was really managed by their parents, usually in usual scenarios. And then because health issues persist and can sometimes also worsen over time, patients really need to identify adult providers, including a good primary care doctor, which is important, as well as subspecialists like the cardiologist, pulmonologist, immunologist, or other important subspecialists who might be needed for their care. So we're talking about the adult population with heterotaxy syndrome, sort of looking over the literature. Still, it's the paper that was published out of our center seems to be the one that's the only paper that's focused specifically on adults with congenital heart disease. So we'll sort of go over the data from this paper. I have to mention that this is overall shows you how limited the literature is regarding adults with heterotaxy syndrome. And this single center study is sort of a very select group of patients. 62 patients total with a median age of 32 years old, and a very high percentage of which 65% had a bachelor's degree or higher, which is higher than a general US population, showing that it sort of requires, with higher education often comes insurance, and many patients would require insurance to be seen in the cardiology clinic. So a selected group of patients to be sure, but also at a tertiary care center. These data might not be relevant to all patients with heterotaxy syndrome in all scenarios, but still important nonetheless to review. So how are patients monitored in the adult congenital heart disease clinic? We monitor the heart and heart physiology in a number of ways. The usual, very common way to monitor the heart is with imaging modalities, and then echocardiogram is nearly ubiquitous in cardiology clinics. Very good for cardiac function and valve function as well, especially when patients have good acoustic windows. You can see inside the chest pretty well. So, but some patients have are more challenging to see the cardiac structures with echocardiogram, and some cardiac structures are just not well seen at all on echocardiogram, no matter how easy it is to see inside the chest. So other imaging modalities such as cardiac MRI are employed. This can also give physiologic data, which can be very helpful at times, as well as CT scans, which are very good for anatomical, defining anatomical details, but are less likely to give you important physiologic information like heart function and flows through the heart and things like this. We also monitor heart rhythm or electrophysiology, including with sort of a snapshot of the heart rhythm with an EKG, or potentially longer monitoring of the heart rhythm with a Holter monitor, loop recorder, sometimes implantable loop recorders. And if patients need a pacemaker or defibrillator, these devices can also monitor the heart rhythm. We use blood tests to monitor end organ function like kidney and liver function. And some blood tests can tell us a little bit about the physiology, what's going on with the heart, including heart stretch marker, heart pressure marker with a BNP or NT-proBNP, as well as markers of a heart injury like a troponin, which may or may not be employed by all cardiologists. And then patients will also undergo functional testing which can include exercise tests. This can be important to sort of show if there's any cardiopulmonary or heart-lung limitations, and then also to see how patients, if there's improvements or declines over time with serial exercise testing. And also heart catheterization tells you, can tell us a lot about how the heart is handling fluid, the work of the heart, pressures inside of the heart, as well as defining important heart structures with angiography. So unclear exactly how frequent we should be, cardiologists should be sending these tests, and then it's important also to think about the frequency of testing, because often, medical testing visits to the specialties and subspecialists can be expensive. We have some recommendations from the adult congenital heart guidelines, and but really testing will be dependent on sort of the patient's anatomy, how the patient is doing, and also the sort of preference of the cardiologist probably as well. When we're thinking about patients in terms of outcomes, we often think about how the anatomic complexity or how complicated the heart is, how that relates to the outcomes. And we know that, generally speaking, the more complex a heart is, the more difficult the cardiac outcomes can be. And some very complex hearts are associated with early death and experiences of heart failure and arrhythmias. So when we looked at the patients in our heterotaxy cohort, we saw that patients' anatomy greatly varied. However, overall, this was a very, this group of patients had very complex anatomies. You can see in patients with polycythemia or also left isomerism syndromes, and in patients who had heterotaxy, but difficult to define exactly which syndrome they'd have, about 50% of those patients had single ventricle or sort of Fontan type hearts. And then in patients with asplenia, which would be like the right isomerism, full 90% of those patients had a single ventricle type physiology or anatomy of the heart. Despite the variations in anatomical structure and physiologies, we found that probably there wasn't any strong correlation with any specific anatomic type and overall outcomes. And so maybe there was a signal for patients who had systemic outflow obstruction, which would be like aortic stenosis or coarctation of the aorta. This gave a clue that perhaps these patients have a higher risk for survival disadvantage or early death. We saw that patients with structural heart disease did require intervention, and of course, patients with complex congenital heart disease, like heterotaxy syndrome patients, will, in our cohort, many patients required an intervention either in the cath lab or a surgical intervention. So up to 40% of patients in our study saw this. Regarding catheter-based interventions, patients may have received ballooning or stenting of different maybe anatomic narrowings or devices or coils and collateral vessels. A patient required pericardiocentesis. One patient required a catheter-based thrombolysis, so for like a pulmonary embolism. And then one patient who had a Fontan circulation required a fenestration creation in the cath lab. Surgical procedures included sometimes very intense surgeries, including atrioventricular valve replacement, pot shunt, Fontan conversion, or late Kawashima, which is sort of like a late Fontan surgery. Regarding structural intervention, we of course must follow any artificial valve that's been placed in the heart, but sometimes native valves or valves that patients were born with can have can be dysfunctional or become dysfunctional over time. And the graph you see on this slide is a very selected patient group, where these are these are Fontan patients. And we see that Fontan patients who have common AV valves are the are the most likely valves to have issues with regurgitation or needing surgery. Of course, many heterotaxy patients will be diagnosed with a common AV valve. This valve goes along with the atrioventricular septal defect or AV canal defects, which are they're sometimes called. And these valves we know have a high incidence of requiring intervention over time. In the adult heterotaxy group, 30% of patients had moderate or worse AV valve regurgitation on imaging. Sometimes AV valves need to be either surgically repaired or replaced. We know replacement is associated with the most durable outcomes, and really it's replacement of the mechanical valves associated with the most durable outcome. And it's a non-trivial surgery, especially in the face of a patient who might have myocardial dysfunction or a weak heart muscle. So we had the experience of a patient who had not totally normal heart squeeze, who had an AV valve replacement. This patient was also heterotaxy with Fontan. And initially there was some struggle after the valve replacement. So this patient required temporary support with a mechanical circulatory support device. An Impella was placed, and the patient was on this for about 30 days while supported the circulation, and we were able to take this out and use just medicines to help this patient out. This patient's still doing well, not on the transplant list and not with the durable LVAD. And also, there's now more potential options for transcatheter options rather than full surgeries. More transcatheter devices are being developed. And so at least one group has published their experience using a transcatheter clipped rather than a full surgery to improve AV valve regurgitation in a heterotaxy patient. Other important aspects that need to be monitored in patients, adult patients with heterotaxy syndrome or arrhythmias. Generally speaking, we divide those into tachy and bradyarrhythmias, or fast or slow arrhythmias. And we know that these arrhythmias are commonly seen in pediatric patients with heterotaxy syndrome. So it is probably no surprise that many patients with adults with heterotaxy syndrome have arrhythmias. In fact, at age 18, less than 50% of patients did not have an arrhythmia in our study. Rather, a quarter of patients had a tachyarrhythmia or fast. About just under a fifth of patients has bradyarrhythmia or slow, and then about 12% had both slow and fast heart rhythms. We know that the risk for arrhythmias in adulthood, generally speaking, are related to maybe an intrinsic heart rhythm difference of the heart. So sometimes the left isomerism, especially in the right isomerism, can portend a specific arrhythmia risk. But also if patients have the hearts become stretched under pressure, or there's a more stress to the system, including times of illness, for example, if there's scar in the heart from surgery, and as we age, we get closer to being an arrhythmia. So of course, important to watch over time. Regarding tachyarrhythmias, specifically in adults with heterotaxy syndrome, we saw that about 35% of patients had atrial fib or flutter, and then about a quarter of patients had supraventricular tachycardias. And some of the patients required ablation or a surgical maze procedure. Substantial portion, 20%, had a documented ventricular arrhythmia or non-sustained ventricular arrhythmia. And these patients might require an implantable cardiac defibrillator. So really important to note that tachyarrhythmia was associated with a survival disadvantage with a quite high hazard ratio. And so it should be a clue that things might not be well if a patient with heterotaxy syndrome experiences tachyarrhythmia. Over time, we saw that patients, as expected, many patients will experience an arrhythmia over time. So arrhythmia-free survival was only slightly better than 20% at 40 years of age. So important to be monitoring for this in the cardiology clinic. Regarding bradyarrhythmias in patients with heterotaxy syndrome for adults, we saw that about 22% of patients had sinus node dysfunction, about 10% of patients had AV block requiring a pacemaker. We did not see a survival disadvantage with bradyarrhythmia. And then over time, the graph on the previous slide showed that patients are more likely to experience bradyarrhythmia over time, with about 70% of patients having a bradyarrhythmia at 40 years of age. Heart failure is an important, very important aspect of care in adults with congenital heart disease and also with adults with heterotaxy syndromes. We know that heart failure is the leading cause of death in patients with adult congenital heart disease. Importantly, about 30% of patients, there's not really a universal definition of heart failure in adults with congenital heart disease, but about 30% of patients were diagnosed with heart failure in our experience. And then the median age of heart failure survival was just 33 years of age, so quite young to be experiencing heart failure. About 10% of patients had heart failure diagnosis when they presented to adulthood at age 18. As expected, a diagnosis of heart failure is associated with a survival disadvantage, so probably a low threshold for thinking about referring for advanced therapies or getting a heart failure cardiologist involved when a patient with heterotaxy syndrome is diagnosed with heart failure. So, speaking of advanced therapies, what can be done after a patient with heterotaxy syndrome is diagnosed with heart failure? Depending on the heart anatomy, there's disagreements about how well medicines work. Certainly, at some point, a heart transplant might be considered. Among adults, Fontan patients, specifically a specific cohort of patients, a large study did not see a survival decrease if heterotaxy was present. So that's should be reassuring, but I think that there are some anatomical defects that might not be possible to do a heart transplant in. So it just might depend. But still, heart transplant might be available. And we should also talk about durable ventricular assist device therapy, or LVAD therapy. Sometimes these are used as a bridge to transplant. And so we had a patient who was supported on a hardware device for 4 years as a bridge to transplant. And then some patients might not be recommended transplant, or potentially transplant's not possible. And so a durable ventricular assist device should be considered, especially as the newer generation devices, their outcomes are improving as they're more compatible with blood. And so 2-year outcomes for the HeartMate 3, which is the newest generation LVAD, rival transplant outcomes, which is really important thing to consider. And then we also think about what are the non-cardiac aspects of management, so management of adults with heterotaxy syndromes. For Fontan patients, it's really important to think about things like liver, kidneys, lymphatic system. And generally speaking, adults with heterotaxy syndrome must consider the lungs, like ciliary impairment, as well as collateral vessels and hemoptysis. There could be intestinal biliary issues, must consider splenic function and associated infection prevention. Some patients will have chronic cyanosis and must think about issues related to this. Sort of, it's a lot to have surgeries and be monitored in various clinics, and so psychological and neuropsych considerations should be considered. And then also let's think about pregnancy and family planning. So I think it's important to end this discussion about adults with heterotaxy syndrome on a very important aspect, which is transition from pediatric care to adult care. And again, the success of the pediatric cardiologists and congenital heart surgeons improves survival, but rarely is the heart disease cured. And so transition to the adult congenital cardiologist is necessary. And we know that heterotaxy patients may have a substantial burden of cardiac complications. in order to be seen in clinic, oftentimes insurance is needed. So securing insurance is essential. It's an essential goal for transition. Life can be very fulfilling, but and yet we still might need a medical partnership to help us along the way. So thank you very much for your time, and I'm trying to take any questions or comments of this presentation.
Thank you, Dr. Broda. That was so informative and just a great and important reminder that we need to think beyond just childhood and into adolescence and adulthood as we think about families affected by heterotaxy, and also a great reminder that as we build our HRC3 registry, that we think about adults in terms of our outcomes. So thank you so much for that talk. For our next talk, I'll actually just briefly bring out a question that I saw in the chat. A parent was asking about standards of care in terms of fully delineating the extent of child's heterotaxy in terms of testing and imaging over time. And I promise that question was not a plant, but it was very timely because our next talk is on building a heterotaxy program from idea to implementation. And you're going to hear from three folks on that talk. I'll be speaking briefly. Again, my name is Dave Shidlow, and I direct our heterotaxy program at Boston Children's. You'll also be speaking with my wonderful colleague, Caitlin O'Connell, the nurse practitioner for the heterotaxy program at Boston Children's, who helps me to lead our program. And then you'll be hearing again from Dr. Steve Spurgeon, who is a cardiologist and assistant professor of pediatrics at UT Southwestern and director of the heterotaxy program there. So we'll move on to the next talk. For my portion of this talk, I have a few goals. I'd like to explain the rationale for a heterotaxy program, share some tips to start building a local heterotaxy program, and then introduce the Boston Children's Hospital heterotaxy program. And just by way of background, we at Boston Children's care for a large number of patients with heterotaxy. This shows our data for the last few years. You can see that we care for between 250 and 300 patients or so a year. And what I appreciated was that because many of these patients were coming through cardiology, there was obviously a very cardiology heavy focus to these patients. Lots of detail about the anatomy, about the physiology, and the potential surgical approach. But what happened was some of the non-cardiac issues that can come up with heterotaxy were essentially left as secondary questions or sometimes unknowns before a patient was going for a major procedure. And as everyone knows who is attending this meeting, heterotaxy certainly can affect multiple organ systems. Here's an example of three patients that I've cared for. The one on the left with polysplenia, hypoplastic left heart variant, and biliary atresia. In the middle, a patient with polysplenia, complex transposition, complete heart block, malrotation, and duodenal atresia. And on the right, a patient with asplenia, dextrocardia, and a complete atrioventricular canal defect, biliary dyskinesia, and malrotation. And so I started to wonder how all of these abnormalities were interacting to affect the well-being of any given child. I wondered what was the best management strategy, what was the best order to treat things. And I wondered if a multidisciplinary approach would be helpful in caring for a child. And so really the mental model for caring for a patient with heterotaxy shifted from something that looked like this to something that was a little bit more balanced and addressed all of the potential organ systems that could be involved in a patient with heterotaxy. So over the next few slides, what I'd like to share is just some thoughts about how we went about building a heterotaxy program. And so I'll take you through our initial steps, how we then went about operationalizing our program, and then share some ideas for ongoing success. So first and foremost is to identify the patients with heterotaxy. And I'm actually going to let Dr. Spurgeon speak in more detail about this in just a few moments. But suffice to say, this is a critical question. It's not always easy. And sometimes just deciding how a patient is going to be defined as heterotaxy can be a complex question. Certainly, a critical component is to identify providers who are willing to be institutional champions. These can be individuals in your department or across departments. It can be as simple as looking on your hospital website or perhaps speaking with division chiefs in other departments. As far as an initial team goes, we felt that having a robust cardiology presence, immunology presence, pulmonary presence, GI presence, and genetic presence were really the key components. And the reason I say presence and not a specific provider is that this can look a little bit different from institution to institution. Certainly, as far as cardiology goes, electrophysiology can be very helpful, seeing as many, if not all of these individuals will have heart rhythm disturbances. Having partners in intensive care and in advanced cardiac therapies or heart failure transplant was very helpful. And then among surgical colleagues, those with expertise in complex anatomy and situs abnormalities can be very helpful. I list next immunology, hematology, or infectious disease, and that is because I think any one of these providers can help to address the immune dysregulation that can occur in heterotaxy. And it's really not so much about having someone from a specific department, rather it's more about having an individual who's interested and motivated to help care for these patients. With regard to pulmonary medicine, hopefully that's evident at this point in the conference. Having a provider who can help care for individuals with ciliary dyskinesia, but also having a partner in ENT can be helpful. With gastroenterology, certainly having a partner in hepatology can be helpful, given the possibility of biliary atresia, and then having a partner in general surgery can also be helpful. In terms of operationalization, defining the initial target population is important. And then what I would suggest is growing in a stepwise fashion. So we began with neonates in the intensive care unit because they were a captive population, if you will, and relatively easy to do consultations and communicate with providers in an ongoing fashion. We then moved on to all inpatients, then regional surgical patients, and then any patients who were seeking an outpatient general heterotaxy consultation. And then one of the things that I'm most proud about our program is that we've moved on now to doing prenatal consultations for families affected with a prenatal diagnosis of heterotaxy. It's important to clarify the process, especially with regard to documentation and billing. So things that one wants to consider are these going to be individual consultations with each subspecialty doing their own consultation? Or will there be one individual bringing everything together and creating a summary note, or maybe a combination of the two? Will these be inpatient consultations only, inpatient or outpatient, or some combination? And what is the cadence of visits and documentation that is going to be a part of this? And also exploring with billing and financial will be helpful to make sure that you're getting adequately reimbursed for the services that are being provided. Meeting regularly, refining the process, and learning from one another is also critically important. So having some sort of forum we can get together and review patients has been extraordinarily helpful. I know I learn something new every time I gather with other providers in our heterotaxy program. And then in terms of ongoing success, support is important. You'll want to look for funding opportunities potentially. We have a program coordinator that is extraordinarily helpful in gathering together all of the information and prior documentation on our patients. We're extraordinarily fortunate to have a nurse practitioner supporting our team, who you're going to hear from in just a moment. That's Caitlin O'Connell. It's important to engage trainees. Heterotaxy can be intimidating, but it can be very engaging. And what I found is that many fellows and residents very much enjoy caring for patients with heterotaxy. And then finally, collaborate, especially as the HRC3 continues to grow and is supported and collaborates with the Heterotaxy Connection. There's going to be more and more opportunities for collaboration. There is a forthcoming Heterotaxy Care Toolkit, a forthcoming registry, and we hope that this will evolve into a yearly conference. So this is our current Boston Children's Heterotaxy evaluation. I don't have time to go into each individual detail, and much of this you've already heard. But this is our approach, which we've evolved toward after a few years of being a program and lots of refinement. And I will say that this largely aligns very closely with the review paper. Many of the authors you've heard speaking here today. So this is a great resource to look toward, in addition to resources forthcoming from the HRC3. And this is our program. I won't read every name, but suffice to say, I am very honored to participate in the care of children with heterotaxy with this wonderful group of individuals. And we remain very available to answer questions should they come up. And with that, I will turn it over to the Boston Children's Heterotaxy Program Nurse Practitioner, Caitlin O'Connell.
Hello, and thank you for that introduction, Dave. My name is Caitlin O'Connell, and I am the nurse practitioner for the Heterotaxy program at Boston Children's. Okay, good. I will be speaking to you today about the nurse practitioner role for our program, as well as the multidisciplinary collaborative process that we use. So as the sole NP for our program, I get to practice in a variety of different care settings, and my role shifts depending on where I am meeting a patient. Some of these settings include the maternal fetal care center, where I meet with expectant families whose child is suspected to have heterotaxy. On the inpatient side of things, I meet with families in the CICU and the cardiac step-down unit, as well as other units like the newborn nursery. And on the outpatient side of things, I meet patients in clinic, as well as virtually through Zoom visits. My role is varied, and I get to wear many different hats every day, and I'm going to walk through what some of those are on the slide. So the first thing I do when we receive a new referral is to don my detective hat, and that is to see what workup has been done previously. This includes digging into the BCH archives or our records from a child's home institution and looking at all the available data to see that we can understand as much as possible about that child and how heterotaxy has manifested in that child. Our goal is to never repeat any workup that has been done previously, but rather to complement what has been done in order to round out what we consider to be a complete heterotaxy evaluation. Depicted on this slide are the 5 main components that make up what we consider to be a comprehensive heterotaxy evaluation. And this mirrors the heterotaxy management and guidelines paper that Dr. Schillo just showed the citation. Once we've reviewed all of the available data and I get the opportunity to meet with families, I get to don my educator hat. And this education occurs individually with the child and family. And this occurs either virtually or in person, where we review what workup has been done thus far, what evaluations may be available to the family to consider. And then I also take the opportunity, of course, to do a comprehensive heterotaxy education session with families, helping them to understand terms that they may have heard many times before, but may not have fully grasped. So for example, what is intestinal malrotation? How does it develop? And when do we screen patients for this condition? So we walk through all of these topics, usually in the form of a PowerPoint presentation. This is an example of a slide that I use when I'm going through my presentation with families. So this one in particular is talking about the immune system and shows images of polysplenia and asplenia and the different evaluations that we use to look at somebody's spleen status and their overall immune status. As I'm sure you can imagine, families come to our meeting with a variety of different levels of experience and knowledge about heterotaxy. So I do my best to tailor my time with each family to what they do. Once we have done this initial intake with families and they have decided which evaluations they would like to pursue, I get to wear my coordinator hat. And that means working with our lovely program administrative assistant to coordinate an itinerary for children and their families, which includes referrals to some of the services that you see listed here on the slide, coordinating any testing that is needed. And then after the fact, when children are inpatient, I get to wear this hat again as children are getting ready to transition home, at which point I make sure that all the workup that we intended to do was actually done and that the families have all the information that they need in order to. The air traffic controller hat comes into play for those children and families who are coming to Boston Children's and we're able to do in-person evaluation. So the majority of these children are coming for cardiac catheterization and for cardiac surgical interventions. And we work to integrate their heterotaxy workups into the care that they are already receiving. So some examples of this are for children who are having an immune evaluation with our immunology team. We'll draw the labs that are needed for that evaluation at the time of another blood draw, or perhaps in some cases during a cardiac cath, for example, cath is available. Another example would be children who are being evaluated for primary ciliary dyskinesia, doing their nasal ciliary brushing at the time of an anesthetic procedure. So they don't have to incur any discomfort at another time. Then once all this data is gathered, then I work with our heterotaxy team of specialists to come meet with the families, review the data that we have gathered, and provide any recommendations and education about this area. Lastly, I get to wear an ambassador hat. And by this, I mean when I'm able to provide education, of course, to the families, but also on a broader scope, seeking opportunities to speak about heterotaxy and lecture about heterotaxy. This can occur on an informal basis and a more formal basis, not only within the Heart Center, but also within the hospital at large, and of course, beyond the hospital. This also refers to our remote second opinion process, where there are children and families who may not be able to travel to Boston for in-person evaluation, but we still review records and help to provide care guidance for those families so that they may pursue their heterotaxy evaluations. Just a moment to talk about our multidisciplinary collaborative process. Dr. Shildler did mention briefly that we do meet on a monthly basis, our team, and we review children that have moved through the program. This is a great learning experience for all those involved. I go through what all the workups showed, and we really are kind of learning from all of our team members. I also, in addition to this monthly meeting, I meet with our heterotaxy special team members once monthly, where we review incoming patients. So to make sure that we have developed the appropriate heterotaxy care plan for each individual patient as they move the program. So both of these ways are really helpful ways to kind of make sure that we're all staying on track and all have the same information. And lastly, I just wanted to share this slide, which is a map of all the home states of the children that have been evaluated by our program since May of 2022, when I joined the program, so up to 29 states and 9 countries, which is really remarkable. Once a child has been evaluated by our program, there's always an open line of communication for anything that they may need in the future, whether it's talking to the PCP about vaccine recommendations or whatever a family needs. So I will turn this over to Dr. Spurgeon in a moment, but just wanted to share that there are many facets to my role. I really enjoy my role as the heterotaxy program NP. It is really a privilege to work with these children and families and play a small role in making sure that they are receiving the best care possible. And with that, I will hand it over to Dr. Spurgeon.
All right, well, thank you very much. I want to start by just saying how grateful I am to Dr. Shidlow and Dr. Ware and Caitlin and the rest of the HRC3 members for their mentorship over the last few years. The goal of my slides here is to show an example of how the multidisciplinary model of care for heterotaxy patients can be adapted to individual institutions while standardizing clinical practices and data collection for eventual collaborative research. So towards the end of my fellowship, I was asking the following questions. What are we doing right now for these patients? What have our outcomes been thus far, and how can we improve those outcomes going forward? And I realized that my first task was just to get help. So that meant reaching out to Dr. Shidlow and others, finding the people who would partner with me locally, And then I needed to correctly identify my local patient population. And then I would be able to determine what changes needed to be made and actually make those changes, track our hopefully improved outcomes going forward. So the first step, finding local partners in various disciplines. This was actually the easiest step for me. I was fortunate to find great partners in key disciplines who either had active research in the related areas or were very interested in participation in caring for these complex patients. Special shout out to Dr. Rivera Sanchez, our local expert on PCD, and Sheridan Waits, one of our talented nurse practitioners and mother of a just delightful little girl who has heterotaxy syndrome. Sheridan is active in the Heterotaxy Connection and presented at the latest meeting. The next and much harder step was to find our patients. There's a general sense that we had a lot of them out there, but there's no specific coding for heterotaxy syndrome in ICD-10. But there are about 277 different diagnosis IDs that I found attached to patients with heterotaxy syndrome just in the chart. And so I was able to combine a direct search of these IDs through Epic with a direct search of echo reports to cast a really broad net and try to pull out and catch every single heterotaxy patient I could find. And this pulled out a little over 1,000 patients, and then kind of a manual curation and chart review of that list eliminated about 75% of them. And that left me with about 19 new heterotaxy diagnoses per year and a kind of a total population of around 274. There were a lot of patients in the initial group that were labeled with suspicion of heterotaxy and a prenatal diagnosis, and then things got copied forwarded in charts, and the inaccurate diagnoses persisted. But of those patients, the 274 patients with heterotaxy that looked legit, the diagnostic workup was widely variable. Based on the information presented in prior talks, which highlight a need to classify isomerism of multiple organs, I wanted to look at things like bronchial arrangement, splenic anatomy, as well as cardiac anatomy. And only 62 of those patients, retrospectively identified, could be fully anatomically classified at every level. So there was a clear need to standardize that diagnostic and imaging workup process. So going forward, we decided to make sure that all heterotaxy diagnoses are assigned the same labels in the chart. I made a little flow chart for staff to encourage getting cross-sectional imaging as appropriate. And we're using the ICD-10 codes and diagnosis IDs listed below. And going forward, the terminology we'll be using in the program will be documented according to the International Society for Nomenclature of Heart Disease, which you see on the right side of the screen, with their coding and their ICD-11 codes. And finally, we've planned a series of kind of standardizing counterpoints with our heterotaxy clinic, with PRN visits and e-consultations available at any time. The roadmap caters to patients with single ventricular heart disease, as you may recall, the outcomes being so critically effective in the setting of that disease, but it can be adapted to any patient diagnosed with heterotaxy syndrome. And the key points of our standardization and outcome tracking will be focused on vaccination rates, antibiotic prophylaxis, workup of splenic function, neuropsychological evaluation, and improving referral rate to pulmonology for a workup of their PCD risk. So that concludes my portion of the presentation and the presentation in all. And thank you all for your attention, and look forward to fielding the questions as they come. Thank you.
Thank you so much for those presentations. We are at 11:50, and actually before we break, I just do want to point out one thing that was noted in the chat. Some folks are asking about what can be done to start local heterotaxy programs, and I just wanted to point out, as Ali Chandra noted, that the HRC3, in conjunction with the Heterotaxy Connection, we are working on a toolkit to help individual centers create their own heterotaxy programs. So keep an eye out for that. That is something that is very much in process, and hopefully we'll have available within the next few months or so. So we are at 11:51 now, and we'll shortly begin our case presentations. But I think that we should take just a 2-minute break. So it's 11:51, almost 11:52 now. So at 11:55, let's come back and we'll begin our case presentations. Thank you. Okay, welcome back. I hope everyone got to enjoy their short break. So we're going to move on with the next section of our conference, and these are going to be case presentations. And it's just really terrific to have trainees who are interested and engaged in heterotaxy, and we're so pleased that they're joining us and going to be presenting today. So we have 3 cases for you. The first case is going to be moderated by Dr. Ken Haber, who's a pulmonologist and director of the PCD Center at Boston Children's Hospital. He is also the pulmonary director of our heterotaxy program here at Boston Children's. And we're going to be hearing from 3 fellows at Boston Children's Hospital, Prasanna Ramachandran from gastroenterology, Yi Sun from pulmonary, and Ben Zielanka from cardiology.
All right, thanks for joining. We'll be discussing a clinical case of multi-organ manifestations of heterotaxy. I'm Benjamin Zielanka, a cardiology fellow, and Prasanna Ramachandran from gastroenterology and Ye Sun from pulmonary will also be presenting with me. So this patient had a prenatal diagnosis of heterotaxy and a single ventricle cardiac defect. They were noted to have abdominal situs ambiguous with a left-sided stomach and midline liver and functional single right ventricle involving a right dominant atrioventricular canal defect and hypoplastic left-sided structures with retrograde flow in the aortic arch. The pregnancy was notable for severe in utero growth restriction, and the patient was delivered at 33 weeks gestation with a birth weight of 1,300 grams. Because heterotaxy can be associated with complex congenital heart disease, a systematic approach to the intracardiac and vascular anatomy is helpful for understanding the range of defects. This table shows a general schematic of common cardiac manifestations in both the left atrial isomerism or polysplenia and right atrial isomerism or asplenia forms of heterotaxy. However, many patients, like the one in this case who had left atrial isomerism, have anatomy that does not fit perfectly into these generalizations. This patient had an interrupted inferior vena cava with azygous continuation to the right-sided superior vena cava, normal pulmonary venous drainage, and as mentioned, had a atrioventricular canal defect in functional single ventricle. There was systemic outflow tract obstruction and normally related great arteries. Single ventricle palliation is an important topic in heterotaxy because historically more than 50% of patients that have heterotaxy have defects that require single ventricle palliation. Heterotaxy is associated with worse outcomes in children that undergo single ventricle palliation, and after the initial operation that's required. This figure shows the proportion of patients that have death or transplantation after the initial operation, and shows that about 30% of patients in this single center series had either death or transplantation before undergoing their second operation, compared to less than 20% in children without heterotaxy. The reason for these differences are multifactorial, but involve pulmonary venous obstruction, atrioventricular valve regurgitation, and extracardiac complications. Returning to our patients in terms of their course, at birth, they were started on a prostaglandin infusion in order to maintain patency of the ductus arteriosus. At 1 week of age, they underwent a hybrid procedure in the setting of prematurity and low birth weight. This involved placement of pulmonary artery bands and continuation of prostaglandins in order to ensure that blood flow would reach the systemic circulation. Over the next several weeks, they remained in the cardiac ICU to achieve further growth. And at 6 weeks of age, they underwent a stage 1 operation with placement of an RV to PA conduit, also called a SANA.
From a liver standpoint, the patient had gradual worsening of hyperbilirubinemia even after the stage 1 palliation and resumption of full enteral feeds, as seen in this graph. The cholestasis was not improved even with ursodiol supplementation. Hepatology was consulted to evaluate the worsening cholestasis. The pattern of cholestasis was consistent with extrahepatic disease. Additional workup was initiated that included an abdominal ultrasound that did not visualize the gallbladder and common bile duct. A hepatobiliary immunodiacetic acid or HIDA scan revealed absence of tracer in the duodenum, raising suspicion for biliary atresia. An intraoperative cholangiogram confirmed the diagnosis of biliary atresia, and a Kasai poroanerostomy was performed with resolution of cholestasis subsequently. The Kasai procedure has allowed for continued biliary drainage in this patient, and there have not been signs of portal hypertension or worsening disease as of now. Biliary atresia is a rare but serious neonatal cause of jaundice, and it can cause irreversible liver damage. The etiology of BA is not well understood. It's thought to be multifactorial, with both genetic and environmental contributions to disease development early on in the neonatal or perinatal period. The Kasai surgery is a stopgap measure, allowing the infant to grow, and most BA patients ultimately require a liver transplantation. The timing of the Kasai procedure is important though, and surgery before 2 to 3 months of life is strongly associated with improved outcomes and reduced mortality. Most cases of BA are non-syndromic, as shown here, but up to 15% are associated with laterality malformations. This study from Germany looked at the prevalence of BA in patients diagnosed prenatally with heterotaxy. Interestingly, in this series, all patients subsequently diagnosed with BA had left isomerism. We also know that BA is associated with direct or conjugated hyperbilirubinemia early in the neonatal period. This study from Houston, Texas, showed that all patients with BA have direct hyperbilirubinemia that is evident right at birth. Based on the results of this study, a screening program was implemented across the hospital to test all newborns for levels of total and direct bilirubin at birth. The program successfully reduced the time to Kasai from a median of 62 days prior to implementation to 26 days after implementing the screen.
From a pulmonary standpoint, immediately after birth, this patient had respiratory distress requiring CPAP support, which he was maintained on between his multiple cardiac surgeries. After this, he was able to be weaned to room air, and also noted after birth was persistent nasal congestion. At around 1 year of age, due to persistent desaturations, he was ultimately started on low-flow nasal cannula. Due to these respiratory issues, he had a PZB workup done, including whole exome sequencing, which revealed one pathogenic heterozygous splice mutation in CCBC39, which is associated with defects in ciliary ultrastructure and tends to be associated with a more severe phenotype. Additionally, one heterozygous VUS and DRC1, which is associated with PCB, along with heterozygous VUS and PDK1L1, which is associated with heterotaxy, was detected. He also had a ciliary biopsy done where the electron microscopy revealed 20 evaluable cilia with pound cilia, which was noted to have normal ultrastructure. Due to the desaturations, he also had a bronchoscopy done, which revealed significant tracheobronchomalacia with almost complete collapse of the left main stem bronchi and 50% narrowing of the lower trachea. During the first 1 to 2 years of life, he had multiple admissions for respiratory issues and had respiratory cultures that ultimately grew Pseudomonas, Serratia, Klebsiella, and Enterobacter. Due to persistent cough, he was also started on daily airway clearance with albuterol, saline, and chest physiotherapy. With his persistent desaturations, he underwent a cardiac cath when he was about 1.5 years of age after the stage 2 Kawashima procedure, which revealed numerous bright lung AVMs with evidence for collateral vessel development, after which he underwent embolization of these AVMs. He also underwent workup for immune dysregulation, had a swallow study to assess for dysphagia, as well as sleep study to assess for potential contributors to hypoxia, which were all negative. Due to the microscopic nature of AVMs afterwards, he did not undergo further embolization. After his final fenestrated Fontaine procedure at 2 years of age, his subsequent cath showed resolution of previous pulmonary AVMs, and he has subsequently been able to be weaned off of supplemental oxygen altogether. His chest X-ray at 3 years of age shows relatively pure lungs, and he is doing very well from a respiratory standpoint currently. In patients with heterotaxy, there's a high prevalence of respiratory disease, and especially ciliary dysfunction. In this multi-center study of heterotaxy patients, Biliary dysfunction was found in a large portion of patients, especially those with abdominal lung laterality defect. It's important to note in the study that none of the patients in this cohort had genetically verified PCD. And similarly in this patient, while he did not meet criteria for genetic diagnosis of PCD, his clinical features such as chronic year-round cough and rhinitis are certainly consistent, and as such warrant treatment with airway clearance and monitoring with respiratory filter. Additionally, airway malformations such as tracheal bronchomalacia has a rare but potential association with heterotaxy, along with lower airway stenosis, which could be associated with worsened clinical outcomes. Lastly, pulmonary AVMs are found in heterotaxy patients. Those with interruptions of the IVC are at particular high risk for pulmonary AVMs. And the cause of this is thought to be due to decreased hepatic factor, particularly as incidents of pulmonary AVMs tend to resolve after resolution of hepatic venous flow, which was seen in this patient. In summary, children with heterotaxy and single ventricle heart disease, multiple extracardiac complication of heterotaxy can be associated with significant comorbidities. In all children with heterotaxy, early screening for direct hyperbilirubinemia and early referral to hepatology is warranted in the presence of persistent cholestasis. Pulmonary assessments or other causes of hypoxia, catheterization evaluation for pulmonary AVMs, as well as workup for PCD and airway evaluations are important. And with that, here are our references, and we're happy to take any additional questions.
So at this point, we'll open it up for any questions and let our moderator, Dr. Haver, and my co-chairs, Dr. Saba and Dr. Ware, help guide the questions.
Steve, would you mind? Oh, go ahead, Ken.
No, I was just going to say, first of all, thank the fellows for this great case. Really highlights some of the medical complexity and also some of the challenges we've been hearing about, over the last day or so, with all the talks about the challenges in understanding the genetics. And I think that's, you just raised that question, and I think really interesting and something that is worth pursuing.
Certainly, I think one of the things that was really interesting about this patient was, is there one genetic mutation that ties everything together? And it seems in this patient, it doesn't seem like there's one mutation. He has one heterozygous mutation in a PCD causing gene and another one that's associated, as Tom pointed out, with heterotaxy and a primary ciliopathy. And I think with Dr. Lowe's presentation earlier, potentially there's a rolling interaction, a polygenic potentially interaction between the two that's causing this combination of symptoms and cardiac complications. And then there has not been nasal nitric oxide that's been done on those patients. I think this mostly because he's been on the younger side, but certainly something I think we are planning on doing as he's getting older.
And DC, you commented on the number of cilia that were seen in the biopsy.
Yeah, so this patient actually underwent multiple ciliary biopsies, and I think this was the second ciliary biopsy that only yielded 20 cilia. And I think that kind of talks about some of the difficulties that on the technical side about doing some of these ciliary biopsies, especially for patients who are younger, and we're doing this intraoperatively oftentimes, and we need a certain number of cilia to really be able to evaluate the ultrastructure thoroughly. So certainly I think we typically want to aim for numbers about 50, I believe, cilia, and he's a little bit on the lower side. So, I think there's still a potential role for repeat ciliary biopsies later on as well.
And I did want to ask the question about screening for bilirubin. should this be all of our patients? I don't know that we're doing that for all of them. Is it? But this case really highlights that maybe we should be.
Yeah, and I can maybe tackle that. Unfortunately, our fellow is, I think, in an airplane somewhere, and Dr. Tracy had to attend to an inpatient. So our current practice is to screen with total bilirubin for patients who have polysplenia, interrupted IVC. And that actually largely came from this patient that we're discussing. I think it's obvious to say that it's not ideal to identify biliary atresia after a stage 1 Norwood type operation. So that's our current practice. So not all patients, but those with polysplenia, but certainly would be very interested to hear what other folks or other centers are doing.
I'll add a
There's a really
genetic comment.
interesting, okay.
I was going to say, I'll add a genetic comment with regard to the PKD1L1. So that gene is expressed in the left-right organizer. So we know that mechanistically it is capable of causing heterotaxy and left-right patterning abnormalities because of that expression profile. It's been described in mice where it's been knocked out, and the primary phenotype, I think, was, if I'm recalling correctly, is situs inversus, but it has been published as a case report in at least one patient with heterotaxy. And I have in the past received a couple emails from people at other centers, the most recent ones from UCLA, I think, about a patient there that had 2 heterozygous PKD1L1 variants in a fetus with heterotaxy, and could they be causative or not? So I think that there is probably some emerging evidence out there for this gene and being a cause of complex laterality defects in patients.
I think we have time for one more question for this particular case. I do see one question that if I can pose to the group, since we have so many experienced folks on the Zoom right now. There's a question about high-speed video microscopy to assess cilia function. And I'm curious as a cardiologist where this is in terms of research versus being in the clinical realm, and where the pulmonologists and cilia experts think this might be evolving.
Ken, certainly, I think you can, oh, sorry.
No, go ahead. Go ahead.
Oh, wait, I mean, I'll just answer, like, for this patient, we have not been able to do, you know, IF or video microscopy, but certainly I would love to be able to do this for all of our patients who are undergoing PCD workup.
Yeah, I just wanted to follow up and just say that with the video microscopy, the difficulty really is there's no standardized way to determine what is abnormal versus normal. That's one of the biggest challenges. And there have been different strategies that people have developed to try to do that. So at the Mucociliary Clearance Consortium, they have a panel of individuals that view the videos together. And then on a consensus basis, having a lot of experience seeing these videos, including patients with PCD, would then call whether in fact there is abnormal motion. So when we started on this journey, we learned from the Mucociliary Clearance Consortium. So we do the same. So when we assess whether someone has abnormal motion, we have a panel of 3 people that view the videos, and then on that basis, make a call. I have collaborated with a couple of faculty and his student to develop a computational method to assess ciliary motion, and we published a paper in Science Translational Medicine. So in principle, we have a mechanism to actually do that. The only problem is that since the student graduated, the faculty that was working on this kind of lost interest in this area. So there's really been no follow-up, but I think that with you know, machine learning and AI now, there's no question this can be done. So I think this really needs to be pursued. And I shouldn't say we're not the only ones. There are other people that have tried different ways to do this in a systematic way. But as of now, there is really no standard. So basically, it's really based on the experience of people looking at these videos to make the call. So generally, that's how it's done. If it's done at all at any clinical center, there's I don't know that people usually use panels, but there'll be someone viewing it and then making a call. So that's something that is a little unsettling. So I just wanted to mention that. But I think this looking at the ciliary motility, is an important part of that complete picture.
Thank you. I would love to continue this discussion for another hour, but we should move on to our next case. Our next case is going to be moderated by Dr. Adam Shapiro, who's Associate Professor of Respiratory Medicine at McGill University. And our fellow presenters are going to be Vincent Lavoie from Pulmonary at Montreal Children's Hospital and Sundus Noor Saeed from Allergy and Immunology at Montreal Children's Hospital.
Hi, first of all, it's a pleasure for us and an honor actually to be here today with you to present at the HRC3 conference. I'm Vincent Lavoie, a second-year pediatric respirology fellow, and I'm with Sundus Noor Saeed, a second-year pediatric allergy and immunology fellow. And today we'll present a clinical case about splenic dysfunction in an infant with PCD and polysthenia. We hope to stimulate discussion about certain issues related to heterotaxy with this case. So let's start off with the clinical case. So this is a case of a 31-year-old female with her first pregnancy, an unremarkable pregnancy until the discovery of a situs inversus totalis on the obstetrical ultrasound at 20 weeks gestational age. The lady then underwent amniocentesis, which revealed to have a normal karyotype as well as a normal QF-PCR. These tests serve to detect the most frequent chromosomal alterations. However, the couple met the geneticist a few weeks later to complete the investigation about the situs inversus totalis, and they did the heterotaxy, situs inversus totalis, and carcinogenic gene panel, and found that the fetus had a heterozygous variance in CCDC40, which is a genetically proven mutation for primary ciliary dyskinesia. In fact, CCDC40 is associated with a worse long-term respiratory disease, and it is also associated with organ laterality defects in PCD, but significantly less complex cardiovascular defects. So finally, the mother gave birth to a boy at 38 weeks. Right after birth, he was admitted to the NICU for tachypnea and desaturation, requiring high-flow nasal cannula. And the course of his NICU was also remarkable for a transient right upper lobe atelectasis, which is pretty typical for PCD. The high-flow nasal cannula was weaned around 10 days of life. As part of the laterality defect investigation, the kid had a chest X-ray, which showed dextrocardia with right aortic arch, an echocardiogram showing atrial situs inversus, but otherwise normal intracardiac anatomy and connection, and the abnormal ultrasound was normal outside of the situs inversus totalis. There was only one spleen on the right side. There was no CT scan or other cross-sectional imaging, and the kid was discharged on supplemental O2 and inhaled hypertonic saline, as well as chest physiotherapy. The outpatient course was not really remarkable. He received the regular vaccination as well as the palivizumab. The supplemental oxygen was weaned around 2 months of age, and he only had one acute otitis media. The regular follow-ups with respirology was unremarkable. However, at 10 months of age, the family presented at an emergency room for 10 days of profuse diarrhea and fever, and the boy subsequently developed lethargy 24 hours prior to the consultation. He was then admitted to a tertiary center, put on IV antibiotics for a presumed refractory septic shock and cardiogenic shock. In 24 hours, the kid was intubated and ventilated due to respiratory insufficiency and had signs of severe and or organ dysfunction with coagulopathy and hepatic dysfunction. The PICU course, during the PICU course, the blood culture grew Streptococcus pneumoniae, confirming the pneumococcus refractory septic shock. The repeat echocardiogram showed cardiac situs inversus, severe left ventricular systolic dysfunction, and the repeat abdominal ultrasound in acute setting showed two small foci on the right adjacent to the large spleen, so likely polysplenia. Unfortunately, in 48 hours, the patient deceased due to strep pneumocystis, refractory septic shock, and multi-organ failure. And the autopsy confirmed the presence of polysplenia with complete situs inversus totalis. So that brings us to some clinical questions, and we'll try to answer these by the end of the presentation. The first clinical question we had is, did this child have functional asthenia leading to lethal infection with an encapsulated organism? To answer this question, unfortunately, it still remains unclear as we cannot assess the function post-mortem. However, we found two studies showing that there might be a correlation between polysplenia and asthenic functional asthenia, as 47% of heterotaxy with bacteremia had polysplenia, and 12% heterotaxy with polysplenia have owl jolly bodies, which are indirect clues of functional asthenia. Again, these are two small studies, so these are not robust data, but at least it gives an idea that polysplenia can be related to functional asthenia. By looking at our own clinical cases, we found a similar case of a term baby girl who had an older brother with suspected PCD but not confirmed, with chronic ear, sinus, and lung infection. The girl at day of life 2 presented with wet cough, nasal secretion, and desaturation, and then PCD was confirmed with 2 variants in IDIN gene. The cardiac echo was normal, the abdominal ultrasound showed multiple small spleens, and the scintigraphy showed no tracer uptake by spleen, confirming the functional asthenia. The second clinical question is abdominal ultrasound adequate for splenic anomalies in babies with diseases causing organ lateral T defects? Actually, current suggestion for lateral T defect screening in PCD coming from 2022 suggests to do chest radiography, echocardiography, and abdominal imaging, prioritizing the abdominal ultrasound for kids. The current suggestion, even if these are old for lateral T defect screening in heterotaxy, suggests that for infant and children, abdominal ultrasound is a reasonable modality to assess clinic anatomy. And if there is an inadequate visualization by ultrasound, compute tomography is an alternative. So, by looking at our case, I think the take-home message from our local perspective would be that every baby should have heterotaxy, because we missed the first polysplenia and the first abdominal ultrasound. And I think to have a good conversation with your local radiologist is key to emphasize on what to look for specifically in kids with heterotaxy and PCD. Abdominal ultrasound is a reasonable first choice, but if there's any doubt or inadequate visualization, we would strongly consider to go with cross-sectional imaging. So now I'll hand to my colleague.
Thank you, Vincent. And now to move to the second part of this talk, why is the spleen important? So the spleen plays an important role in the development of the immune system and continuing providing protection through life. So also it's considered one of the largest secondary lymphoid organ in our body. Without spleen, we cannot do phagocytosis, and we need a functioning spleen to develop antibodies to capsular antigen, and these antibodies can coat opsonized encapsulated bacteria, allowing for their phagocytosis. Furthermore, the splenic phagocyte responsible for blocking the pathogen dissemination. So lack of this early defense barrier can explain increased susceptibility and rapid development of lethal sepsis in asplenia. And those patients are higher risk for encapsulated microorganism like Neisseria meningitidis or streptococcal pneumonia like our patient. So after confirming the presence of splenic tissue, we need now to confirm the functionality of this tissue. So first, we can use the ultrasound, MRI, CT scan, any of the images to confirm the presence of the tissue. But for the functionality, we need more tests. So we can use radiology, hematologic, and immunological modalities, and all together to screen and to confirm the functionality. For radiology, we use technetium scan to measure the uptake of radio-labeled particles by spleen related to the liver. However, this modality not available in each center, and it's costly and carries radiation risk. So we need to look for more screening tool, simple, accessible, and free of radiation. The second part, we can use hematology, looking for the CBC and the blood film. So it can give us a lot of information looking for thrombocytosis, lymphocytosis, and monocytosis. This all non-specific, but can give us a clue for the functionality of spleen. Whole Jolly bodies is a sensitive, but also it's not specific. And sometimes we have a delayed appearance like in newborn, and also it's operator dependent. Lastly, in the hematologic, we can look for the percentage of pitted erythrocyte. And this is a very optimistic tool. It's rapid and expensive and non-invasive. And normally we can see up to 4% of pitted erythrocyte in each individual, but more than 4 can be associated with hyposplenism. We have a couple of studies done in this context, asplenia and sickle cell patient, and they found pitted erythrocyte percentage 15 up to 70%. Lastly, we can use the immunological assessment to look for immune response after vaccination, and this can assess the functionality of the B cell. And in patient with diminished splenic function, we can see low memory B cell. So in summary, how we can determine the splenic function, we can use the percentage of pitted erythrocyte and whole Jolly bodies as a screening tool for potential patient with hyposplenism. And then we can confirm by technetium scan. This is the only confirmatory method we have until now. So what's the goal from all this? The primary goal in all splenic patient to provide adequate preventive medicine. So through vaccinations and prophylactic antibiotic and family education. So for vaccinations, the CDC recommend to give all the routine inactivated vaccines for those patients, and a supplementary vaccine should be given also Haemophilus influenza, meningococcal quadrivalent conjugate, pneumococcal, and influenza vaccine. Prophylactic antibiotic, each patient diagnosed with a functional asplenia should start on penicillin at least in the first 5 years of life. However, if the patient had any history of invasive pneumococcal disease, prophylactic antibiotic should extend it maybe through the life. For adults, we should provide them with antibiotic to be readily available if they have any signs of infections. We should focus on education and awareness for the patients and their parents for signs and symptoms of infections and when they have to seek medical attention. And we should provide them a medical alert card and bracelet for management in case of emergency, and regular medical follow-up to monitor the complication and adjust management is needed. So this is the end of our presentation. I would like to thank my colleague Vincent and Dr. Adam Shapiro and Dr. Bruce Mazer, both are professor at McGill University Health Center. These are our references, and thank you.
Thank you very much. I am responsible for overseeing the questions in this talk, and that's great because I am also a McGill grad. So I'm really proud of those fellows. You guys did a wonderful job. Dr. Shapiro, obviously some exceptional mentorship. A couple questions came in through the chat. I will pose those questions, and Dr. Shapiro seems like is alone today without fellows. Okay, so
Vincent is getting married right now, so
okay,
we let him off for that.
Okay, so he's got a good excuse for not being here today. All right, so first question. This might have been missed, but did the child actually get pneumococcal vaccines?
All standard vaccinations, everything was done. Yeah, and the child did not recurrently grow strep pneumoniae on his sputum surveillance cultures. He grew Haemophilus and a little staph.
Okay, from Caitlin O'Connell, fascinating case, certainly emphasizes the importance of immunology lab evaluation to complement imaging, like we learned yesterday. Is there an age minimum that is more accurate to test for pitted red cells?
So I must have, I'm not an immunologist, I don't know, but I can tell you we don't have access to pitted red cell testing. We have access to the scintigraphy scanning and Howell-Jolly bodies. So I think that's the main problem here is to pull the trigger and do those tests, you have to have access to them, and many places don't. I know we learned yesterday that the pitted erythrocytes are a send out. I think Cincinnati Children's does them, so that was news to me, and I'd like to use that. But I do think in these rare children who may not fall under the heterotaxy heading for a cardiologist, but you find laterality defects, you really, really need to consider doing splenic function testing if there's anything funny about that spleen on imaging. And in this case, we even had a good image that showed it wasn't funny and it was just a bad image, basically. Ultrasound is only as good as the person whose hand is on it, right?
Steve Spurgeon, you had a comment on that in the chat. Did you want to?
Yeah, I've been trying to find the normative data for pit counts. I'm sure it exists somewhere. Our people here locally weren't able to help me find it either. I found one study that was done in children with sickle cell disease, in the kind of newborn up to age year 1. But there wasn't quite enough data there for me to expand it to have formal recommendations. But I do think it's something we need to do, and might be a good opportunity for HRC3 to kind of look at that across the country as we
I do
expand
think it's a very low hanging fruit, and you are preventing mortality. This isn't morbidity, you're preventing mortality by doing this. So I do think it's something that as a group we need to look into.
Okay, next question. Is there a difference in immune function between congenital asplenia and acquired asplenia? Posing this question because many families have run into the issue of being lumped into the camp of sickle cell or post-splenectomy asplenia, causes lots of anxiety that there may be heterotaxy related risk factors. So do we treat kind of acquired hyposplenism the same as congenital hyposplenism?
Well, I think what you're running into is that this literature is dominated by sickle cell, unfortunately, and that's going to be your kind of gold standard everything's compared to. I will say when I see a child come to me at age 10 and we diagnose them with heterotaxy and PCD, but it was a late diagnosis, if they haven't had recurrent sepsis by that point, odds are their spleen is working. I'm a lot less worried. It's in the newborns fresh out of the oven where I don't know what they're going to do in the next week that I'm much more worried that they could die of sepsis. And that's been shown on sickle cell that your risk of sepsis is much higher when you're under age 5. And that's why the prophylaxis is mainly at that age. So I think there probably are differing degrees and differing risk factors. Again, not as an immunologist, but I think we really need to think about this in the babies because it can be truly life-saving there.
Okay, a couple more questions before we move on to the next case. In polysplenic patients with a pit count of 0, does that mean splenic function is normal, or do we still need to pursue more testing with a low pit count?
That's when I wish my immunologist was on. If there's any immunologists on the call, I'd love for them to chime in and let us know. But for right now, I don't know.
Okay, so Dr. Sun answered this one, but I will post it to Dr. Shapiro too. Let's see here. All right, do you find that patients with heterotaxy and tracheomalacia, are there symptoms similar to heterotaxy with PCD? It kind of sounds like the question is kind of, are all different lung diseases in heterotaxy similar, or might tracheomalacia look very different from PCD?
So PCD, there's 4 key clinical symptoms, and it's year-round cough that's wet on a daily basis, starting usually at birth, year-round nasal congestion on a daily basis, starting at birth, an organ laterality defect, and neonatal respiratory distress. So really, someone with tracheomalacia might have intermittent cough and might have noisy breathing, but they shouldn't have chronic wet cough and chronic nasal congestion every single day of their life since birth. And that's the difference. It's really, when you see PCD, it's very obvious. You can try and make a lot of things look like PCD because you want to discover PCD, but it's just not the case. Imagine what I say to people is imagine the worst cold of your life every single day since birth. That is PCD. And there's gentler forms, and we're finding more forms, but it's like that. And tracheomalacia should not be that severe from a wet cough infectious standpoint, but it can be severe on its own.
Sounds very similar to Dr. Sun's answer here. Okay, so basically we're learning that in patients with PCD, there probably is a lot of heterotaxy out there. And as we know, heterotaxy can be pretty serious. PCD Foundation, Dr. Shapiro, correct me if I'm wrong, PCD Foundation is trying to figure out if we want to actually start recommending routine surveillance testing and diagnostic tests for splenic location and function in echocardiograms in PCD, which is not necessarily part of the current guideline, but it might be very, very soon. Is that kind of what things are going to look like for PCD patients?
Well, there's at least I think we have enough evidence now from some of the publications out there to show that any child with PCD should have a screening echocardiogram and some type of abdominal imaging. Probably an ultrasound is the easiest place to start. When you don't have a lot of heart defects and you're not trying to discover what's wrong with all the plumbing to plan for a cardiac surgery, it gets harder to justify irradiating a baby with a CT scan. So I think at least some cross-sectional imaging could be considered, but abdominal ultrasound and echocardiogram are coming. As far as splenic function, that's a whole different story, and we haven't really decided on that. I personally can tell you, after the 2 cases I found, and one baby that died and one that could have died if we'd not found their splenic dysfunction, that whenever there's something architecturally abnormal with the spleen, I am going to do a splenic function test.
Perfect. Thank you, Dr. Shapiro, and thank you to your fellows that presented the case. And Dave, I'll pass it over to you to introduce the third one.
All right, thank you. That was such an interesting case and a great discussion about spleen function, which just is more and more nuanced every time we seem to talk about it. So thank you for that. So for our third case, this is going to be moderated by Dr. Katie Chatfield, who is Associate Professor of Pediatrics. She is dual trained in pediatric cardiology and clinical genetics. She is the Director of the Cardiovascular Genetics Program at the University of Colorado and Children's Hospital, Colorado. And the fellow presenter from cardiology will be Dr. Khalifa Al-Dawsari. Thank you.
Hi, everyone. My name is Khalifa Al-Dawsari. I'm a pediatric cardiology fellow at Colorado Children's Hospital. Thank you for having me today. Our case presentation is about single ventricle palliation in heterotaxy syndrome with a primary ciliary dyskinesia. Our patient was born at 37 weeks with a prenatal diagnosis of heterotaxy syndrome and complex congenital heart disease based on fetal ultrasound and MRI. Postnatally, he was confirmed to have right atrial isomerism and balanced AVSD and double outlet right ventricle with pulmonary atresia and unobstructive total anomalous pulmonary venous return, thus draining to right-sided atrium. Also found to have visceral situs ambiguous with a midline liver and left-sided stomach and absent spleen. Given the complexity of the congenital heart disease, single ventricle pathway was the only surgical option, which typically involves 3-stage surgeries. At the age of 3 days, the patient underwent stage 1 palliation, which consisted of PTT shunt that connects the right subclavian artery to the right pulmonary artery to provide more consistent source of pulmonary blood flow. In addition, had bilateral pulmonary artery reconstruction. Following the surgery, the patient remained intubated for 20 days due to persistent atelectasis of the right and left upper lobes, not responding to conventional respiratory treatment, and had bronchoscopy that was showing bilateral right-sided lung anatomy. However, no significant obstruction was seen. The evaluation of primary ciliary dyskinesia started around the age of 3 months. However, the initial sample of the nasal turbinate was not adequate to provide any information. Therefore, underwent a repeat test a week later that revealed abnormal ciliary ultrastructure with a partial outer dining arm deficiency. These findings were consistent with the diagnosis of PCP. Genetic testing revealed compound of heterozygous pathogenic variant in DNA H5. These 2 variants were associated with the diagnosis of PCD. The medical course between stage 1 and stage 2 palliation was remarkable for malrotation that was seen in upper GI study, and that the patient underwent G-tube placements with the LADS procedure. And despite being exclusively fed through the G-tube, had persistent emesis and underwent nascent fundoplication. Also had bilateral pulmonary artery plasty and PTT shunt upsizing at the age of 4 months, and had cardiac arrest event that was secondary to an aspiration requiring CPR and intubation at the age of 4 months. As part of the evaluation of stage 2 palliation, the patient underwent cardiac cath at the age of 8 months for hemodynamic evaluation and found to have elevated pulmonary vascular resistance and was started on sildenafil. And at the age of 12 months underwent bidirectional Glenn and was extubated on the same day of surgery and discharged home within a week of the surgery. At the age of 2 years, the patient completed extracardiac Fontan. However, the course was complicated by elevated Fontan pressure and reduced cardiac output in the immediate postoperative period, for which underwent Fontan revision on day 2 post-op. Following the revision, required some oxygen and chest PT and positive airway pressure, and the total length of hospitalization was 18 days. Now the patient is almost 11 years old, doing well in homeschool, followed by multidisciplinary subspecialists, including our Fontan multidisciplinary clinic that includes cardiology, pulmonology, gastroenterology, immunology, infectious disease, and our special care clinic. The frequency of hospitalization has significantly decreased since stage 3 palliation. Our points for discussion includes what are the benefits of early genetic versus functional testing in single ventricle heterotaxy patients. Second, are single ventricle heterotaxy patient with primary ciliary dyskinesia candidate for a stage palliation of congenital heart disease? And third, how are primary ciliary dyskinesia patient with a single ventricle physiology best managed? Thank you.
Well, thank you. That's a great case with it poses really challenging questions, I think. It doesn't look like we've had any questions come into the chat yet. I don't know, Katie, if you had comments or any follow-up on this patient?
I don't have any additional follow-up from what Khalifa had presented. This patient's still alive and well. I think some of the points about this case in particular have been nicely covered by other presentations along the course of the talk today, which was really great. But brings up the fact that, these patients are all very, unique, and working them up appropriately when they're newborns is really important. But I'd be interested in your thoughts and others about the utility, or, how universal is it for these types of patients to be getting genetic testing really early in life, which may impact how, they're managed, especially when they have congenital heart disease. This, may be a particular, sort of a rare case based on the evidence that all of you have presented, but still important to, think about how that the genetic information helped to, or would have helped, even if we'd had it earlier, to anticipate what the course for this patient might have been. So I'd be interested in your comments, or Dr. Geddes.
Well, I think it's a great example, and we're very much in a moving target area right now, just because the turnaround time for genetic testing has changed remarkably within the last 3 years. And so, the practice at our institution is that actually, whether isolated congenital heart defects or apparently syndromic or heterotaxy, all of those patients now get rapid genome testing. So we're getting the diagnosis back much more quickly than we were ever used to getting it back in the past. So we're sort of in a new era of what to do with that information. But I'm also aware that substantial practice variation still exists across the country. So I guess I would be interested from hearing from others on this as well, as if there's a standard at their institutions. I mean, we've implemented a protocol in our NICU and CBICU for that. So to the best of our ability, patients are kind of standardly offered that.
Yeah, I'd also be interested to hear from the group about that. I think it's very institution dependent, and whether or not your institution is willing to support the cost of genetic testing if it's not necessarily done within the roof of your house, and if it's a cost to the the hospital. So we likewise have our institution's been very supportive of allowing us to do genetic testing, but there's still no kind of one size fits all, and rapid testing is not necessarily done in every patient, although every patient is offered genetic testing. So I'd be interested to hear about the group, because I don't think it's a although some of us take it for granted, it's not necessarily standard of care at many places around the United States.
And something that I feel like we've also seen a bit of a shift in over the past few years with rapid sequencing is we have this amazing ability to get results so quickly, but we're also sort of causing parents to process even more complex information regarding secondary findings and some nuances of genomes and things like that. And obviously for any major cardiac malformation, that can be overwhelming. But for heterotaxy patients, where I feel like in some ways it's the most important, it also might be the most overwhelming because they have the most going on. And so I haven't specifically looked at that, but I do worry about that for communication with our families, because it's a lot to put on them. But at the same time, it's like, well, why would we wait to do rapid testing? That defeats the purpose of rapid testing.
I also love how the first case had a less straightforward genetic testing result, which in this case we were a little bit more fortunate that it was it was consistent with what was going on with the patient, but that's clearly not always the case.
So coming from like the PCD world, I can tell you that a lot of patients who have PCD come to us and say that their cardiac surgeon is reluctant to pursue, a certain type of surgery or any surgery at all, because there is an assumption perhaps in some institutions that PCD puts somebody at an unacceptably high risk for surgery and the outcomes are poor, et cetera. And I think there might be some truth to the fact that post-op outcomes might be less favorable with other comorbidities, but the PCDF Foundation is strongly saying that with appropriate care and antibiotics and pre-op and optimization of care, there really should never be any reason, the PCD should not be a reason to withhold important surgery from patients that have PCD. And I think hopefully this particular organization, the HRC3 and Heterotaxy Connection, can also be somewhat unified in that statement to allow patients to get the care that they need and to not let their comorbidities significantly limit what might be a major intervention for them. So the PCD Foundation with Heterotaxy Connection are working together to promote that message.
Thank you so much, because for saying that, Dr. Saba, because it was sort of maybe a blessing that this patient got a slightly later diagnosis. It's hard to say, because if the surgeons had known from day 2 or 3 with a rapid genome that this patient had a diagnosis of PCD, there may have been a lot more reluctance to pursue his first and second stages of palliation. Although he was diagnosed by the time he had his second stage. On the other hand, if we'd known about it a little earlier, it might have changed slightly how his pulmonary management was addressed. But that's another excellent point that I wanted to bring up by having Khalifa present this case.
I would like to chime in here in that, we did a study previously that showed that subjects with low NO, single ventricles patients in particular, are much more likely to either suffer death or need a heart transplant. And I bring that up mainly to really suggest that the patients that may have PCD and single ventricle lesions should be prioritized for heart transplant. I think that even though knowing that you have PCD might cause surgeons to hesitate in terms of providing the 3-stage palliation. In fact, I think these are the patients that actually should have the highest priority for getting a heart transplant because they're really at high risk for heart failure and death. So I just want to mention that as something to consider.
I appreciate you saying that, Dr. Lowe. That's certainly something that was worthy of additional conversation. I would just add that as also being a heart transplant cardiologist, you add the additional component of immunosuppression in these patients with PCD, which, also is going to raise potentially some questions from a heart transplant community about, because I don't know that we have robust outcomes data yet that tells us how patients with PCD do post-heart transplant. So it's a very important question that hopefully we can address through this collaboration.
Okay, well, thank you. That was a great case. I think we had 3 really excellent cases that serve to summarize some of the real complexities that we see in this patient population. And so I think now I have the opportunity of being able to begin to wrap us up a little bit. And so, first I want to thank Dr. Tom Saba and Dr. Dave Shidlow for all of their really hard work on organizing this conference. I will say that they did the bulk of the work, they and Nisha Saban, in terms of really coming up with the outline and getting this together. And also want to thank all of the speakers who I think all did a really excellent job, very prepared and polished and knowledgeable talks that I think were informative to everyone on this forum. And then all the participants. We had over 200 people register. We had great attendance yesterday, great discussions yesterday, and I think today has been just as successful. So it's really great to see all of the different specialties represented here, to have the input of the parents and families who can share their wisdom with us of everything that they've learned over the years and can help us be better as providers in terms of what the needs are, how we can move things forward. And then, finally, just need to thank Heterotaxy Connection and recognize them. I've known Nisha Saban for a decade now. Heterotaxy Connection was in existence before I met her, but, I think we have found, and especially those on this call who are in the PD world, are really well aware of how parent advocates can make such a huge difference in being able to drive science, drive outcomes, drive physicians and other care providers, and motivate them to really be able to do better things in terms of taking care of patients. So I have to really thank her for her persistence and for being the driving force behind much of what's gone on in terms of this forum and the opportunity to bring people together. And so I will turn it over to her for some of her final words.
Thank you so much, Stephanie. I appreciate all your kind words. We definitely wanted to take a moment and thank all of our speakers. Thank you for the time and effort you put in preparing your talks and sharing your expertise with us. Thank you to the participants, everyone that has joined us. We've had medical professionals, we've had researchers, we've had families. It's been a beautiful thing to watch everybody interact, to watch the doctors answering family questions, to answering different questions coming up from different medical professionals. It's been very beautiful. Just to let everybody know, we will have these videos up. It'll take about a week. They will be both on the Heterotaxy Connection website, which is just heterotaxy.org, and HRC3 website for you to be able to view. Please share that. We want this to go to anybody and everybody that has interest in heterotaxy. The knowledge is powerful and can help many people. We will be sending out information this fall on how to develop clinical centers and have a forthcoming toolkit for that. Also, if you would like to help, please reach out. We will be sending out a newsletter to everybody that has been registered with more information on that. And then I just wanted to take a moment. I am the executive director, but I'm also a mom of an 18-year-old daughter with heterotaxy that is fierce and will take on the world. But as a parent, watching this has been just phenomenal. Watching doctors and different specialists talk to each other has just been so touching to me. I've often been in tears throughout this. The benefits of keeping these conversations will help so many. It's going to help those that haven't been diagnosed yet, those that haven't been born yet. It'll help those that have heterotaxy and are currently fighting their own fight. Rachel, who spoke yesterday, her son was actually admitted last night, and that's pretty typical for heterotaxy. So very helpful, and then just helping down the road for everything that's to come. I am so incredibly grateful for that. We want to keep these conversations going. We want these talking points, these questions that come up, and this expertise and knowledge as we talk and interact, it just brings power. So thank you so very much from the bottom of my heart for all that everyone has been doing, especially for Tom and Stephanie and Dave. Thank you for all you have done and continue to do. And I look forward to what we can do for Heterotaxy together. Thank you.
Well, with that, we will wrap up, and definitely more to come in the future. And we will look forward to tapping into everyone's expertise more as we go forward and continue to work to make the outcomes better for these patients. Thanks all, appreciate it.